Hello and welcome. My name is Yolanda Hipsky. I'm the Regional Transit Coordinator for the Tri-County Council of Southern Maryland. And today we are holding our first roundtable meeting for about non-emergency medical transportation. The purpose of these roundtables is to create a dialogue between the healthcare and transportation communities in Maryland. And our goal is to come up with identify strategies that will expand non-emergency medical transportation in the state of Maryland. Since spring, we have been meeting as a small working group, and I'd like to take a minute to recognize the members of that group. We called it the Roundtable Working Group. We have Charlotte Davis from the Rural Maryland Council, John Hartline from the Tri-County Council, Southern Maryland. Sarah Seitz is also here from the Maryland Department of Health. Tanya Nichols from MDOT-MTA OLTS. Megan Darcy, also from the RMC. Noelle Flaherty, she's from the Calvert Health Hospital. Jonathan Dayton, he is the Executive Director of the Maryland Rural Health Association. John Dekluski from TAM, Executive Director. Michael Cornett is also from TAM. Oh, so yeah. Yeah, of course.
We appreciate you being here.
Well, as I was just gonna, thanks. I was gonna say every community offers programs that support non-emergency medical transportation. And here in Cambridge, the Delmarva Community Services Organization is very unique. The organization has been providing transportation from local transit systems, Medicaid to volunteer work. And to tell you a little bit more about what they do, I'm honored to introduce Sandy Brandy, who is the director here at DCS.
I'm going to take a couple minutes and to let Steve also say a few words. Steve has the job of being our transportation expert. Well, we've done transportation, or we continue to do transportation probably for the last 20 years. We're the MTA recipient of all the regional funding for the 5310s, 5311s, STEP. They're all MTA funded, FTA funded programs. And luckily for Dorchester, Delmarva, we've been able to run all the public transit in approximately 4 or 5 counties, and we do non-emergency medical in about 3 counties now. So we keep busy. We have a fleet of about 60 to 70 vehicles out on the road every day, and that each vehicle has a driver. So our transit program employs at least 60 to 75 people, and our agency in and of itself employs over 300 people. So we have 20 some group homes between the state of Delaware and the state of Maryland for people with developmental disabilities. We have the senior services in 3 counties. We provide all the home delivered meals program. Our kitchen puts out 300 meals a day. So it's a wide variety of services. Primarily, we were created as developmental disability services, and then everything has grown from there. And now we do seniors. As you saw, there's a lot of seniors in the building today. So we're the local funded senior center program. Disabilities, like I said, we have 20 some odd group homes, all the day services, vocational services, job placement services, and on and on. I don't know, Keith, you want to talk a little bit about transportation? And
sir, you covered everything I was going to say. I'm just kidding.
Oh, he's got a sense. He has a sense of humor too. Luckily, someone here does.
Thank you very much. I'm Keith Atkins. I'm Deputy Director for Delmarva Community Services. Just to give you a little background, our transit system covers 4 counties on the mid shore, which includes 14 deviated fixed routes, 5 fixed routes, 1 stop service that provides door-to-door transportation for persons with disabilities, veterans, et cetera, that are unable to ride. Okay. All right, thank you. We started up in January of this year a partnership with Talbot County, a Talbot Mod, which is very similar to a microtransit that's working out very well. We also provide transportation for seniors to senior centers, field trips for seniors and youth that are enrolled in nonprofit agencies that are trying to keep them on the right track to success in life. We're very proud to partner with them. As Sandy said, our fleet consists of over 60 some buses and 40 smaller vehicles, which include vans and cars. We have dispatch centers in Cambridge, Denton, and Chestertown. We currently use a software program to dispatch all of our drivers. The drivers have tablets, so it's on time. And if someone bus, and if it's available, we can dispatch that bus to that person. So that's working out well. It also tracks our MTA requires us to track deadhead miles and passenger miles, fares, no shows and cancels. So, and I know we're here to talk about some of that information today. As Sandy said, we do provide all of the MAT for Dorchester and Talbot. We provide adult daycare and wheelchair for Kent County, and we're have a proposal out for another county on the mid shore for possible service. We provide, excuse me, we provide over 2,000 MAT transports a month. You know, I know John asked me a few questions about, you know, to go into that. Part of that is a large part of that is treatment for methadone. We are seeing an increase in that in the past 2 years, that we've actually got to the point that we've had to designate 1 bus just for the transports because some of the passengers prior to and after the treatment are not very public friendly. That's a concern and issue that we're dealing with on a day-to-day basis. And that ranges from passengers that steal from other passengers, passengers that we've caught doing drugs, selling drugs on the buses. It's really an issue that we're facing that has become a challenge every day.
I mean, the one instance we had when our video, with the vehicle had video, and they literally were exchanging their drugs for money with each other across the aisle in the bus after they got on the bus, after they came out of the clinic to get with their drugs. They then sold them to other people on the bus. It's really difficult.
It absolutely is.
So just to give you some numbers that on average, out of those over 2,000 MAT trips, we have on average 93 passengers that are no-show for 319 trips. So we're sending people out, drivers out on buses to pick these people up, and they won't come out of their house or whatever. And then we have a total of 120 passengers that cancel either the morning of or the evening before after the schedule's been made. So that's become an issue. Part of our service we provide also is that we have on average 22 passengers that require medical assistance that are not eligible for Medicaid. That has really become a challenge, but we try to get them on our medical bus and provide the best service we can for them. You know, we're like everyone else, we're facing shortages of drivers, availability,
repairs to buses due to supply issues. We do work very well with our transportation managers at the health departments that we have agreements with. But there's times that things occur that we have to resolve at the last minute. I'll finish by saying that we have a great team of drivers, dispatchers, and mechanics that service the midshore. They do an outstanding job, and I will open it up for questions or comments.
Yeah.
What kind of scheduling program will you?
We're using shop software. Yes.
We also like to thank Andrea Waters, who has been our statistician for the last
27 years.
only feels like 20 some years, 27 years, but counties to the consumers, to the state of Maryland, to the federal government. But we do appreciate the work of Andrea. She's been with us for 27 years and she's really kept us together statistically and she does a great job for us. So we really like to thank Andrea. So, and Keith, now that he's the new guy on the block, but he's been handed a diverse transit system. You just don't realize how diverse it is and how difficult it is to manage and how to keep all the county governments happy, who seldomly are happy, but we try and keep them as happy as possible because we have to reach out to them for funding and matching funds so that we could draw down the state and federal funds at the same time. It's the local government support is very important to us. If we didn't have that, we'd have a hard time drawing down the federal match and the state match. So it's a little complex about what we do, how we do it, how many people we serve, who we are serving, whether it's a disabled individual from Dorchester or seniors from the various counties. It just is, it's a difficult job, and we appreciate working with everybody and we appreciate the support of the counties. But it is difficult. I mean, like I said earlier, you're doing a job of taking people to the methadone clinic. They come out, they have their medication, and then we're looking right on the camera and they're literally selling it. They're exchanging money across the aisle of the bus after they come out of the clinic, and they're selling it to each other. So it's a very bizarre way to live, but it's hard. It's hard on our bus drivers too. I mean, they have to be vigilant, and a lot of them didn't come come to be a bus driver
Right.
to feel that they would be vigilant or like a deputy sheriff in a sense. It's very difficult for a lot of them, but we appreciate the support of the community and the support of our staff and the funders out there. So that's about it for me. But anybody else? You want to say anything, Andrea? No, thanks. She just loves her numbers. Who wants the mic? Anybody? Who's in charge of the mic?
I got a little stand right there.
There it goes.
Thank you, Keith and Sandy. That kind of captures a lot about what we're trying to accomplish here to provide non-emergency medical transportation. It is a balancing act between funding and between taking care of the clients themselves and making sure that we meet those specialized needs that they have. So today is our first roundtable meeting, and that was our topic, is non-emergency medical transportation. And I promise you that we will not find solutions today. In fact, I hope that we leave with more aha moments than we have solutions, because each of these meetings, and we're going to have a total of 3, builds on the previous ones and on builds for the next one. For example, today we're going to define what non-emergency medical transportation is. We're going to review some of our current programs, and then we're going to review some of our surveys. We had as you know, we had during the summer, we sent out a survey to many groups around here. I think we have more than 300 responses back, which is a healthy number for the topic. And, you know, we are going to be reviewing that on October 25th, 1 month from now we will be holding our second meeting at the Maryland Rural Health Association Conference at Rocky Gap, Flintstone, Maryland. And at that meeting, we will be reviewing and analyzing some of our findings from today and see if there's any possible concepts that we can have for strategies. And then I encourage the participants from today to contact the Maryland Rural Health Association about attending this meeting, because this is where we start conceptualizing a few ideas. This is where it gets exciting, to be quite honest. And then on November 17th, which I'm sure everyone has marked on their calendar, is National Rural Health Day. We will be meeting in Annapolis at the Maryland Department of Agriculture. So what exactly are we here trying to do? You know, about 100, 150 years ago, kids used to walk to school, you know, and I'm sure y'all heard the story. It was in the snow in July, 5 miles uphill both ways. That's right. And then in 1886, someone in Indiana, Wayne County, Indiana, got the idea is that if we could put all these kids in a wagon and haul them to the school, they might learn something. They might learn something a little bit better than they would have otherwise. And there you have it. Voila. You had the modern day school bus. And I bring that story up because you see, that moment in 1886 was a paradigm shift. At that moment, someone realized that we would be better off if we picked up the kids and took them to school, and they changed that thought process. And I bring this up because that's what we're talking about, non-emergency medical transportation. We're, you know, normally there is a perception that it's Medicaid only covered, but we're talking something beyond that. We're talking about the 10-year-old kid who has a cavity, but dad's car broke down. And he can't get to the dentist that lives 15 miles away. We're talking about the dialysis patients, you know, and dialysis patients have an employment rate, not unemployment rate, but employment rate of about 20%. We're talking about picking up that dialysis patient who needs 3 times a week, 4 hours a day. They have to sit in that chair 12 hours a week in order to live, so that they keep out of the emergency room. That's what we're talking about when we say non-emergency medical transportation. We're talking about a paradigm shift. So just real quickly review our schedule for today. For the next hour, we're going to review our current legislation and regulations and programs. Then we're going to have a lunch hour, and then we're going to review our survey results and see if we can find some preferred trends. And I can assure you we should be done and out of here by 2:30. So we're going to have a polling question. We're going to ask everyone to go to polling everywhere. Where is my polling question? No, this was the one I did before. I was the one who downloaded it, and I was able to actually work it. It's a good thing we had this question in the beginning of the part of the meeting, so we can figure this out. But we will get back to that, and we'll probably we'll probably be doing a lot of these questions after lunch anyways, but let's just move on. Okay, so here we go. And to help us with this conversation, we were fortunate that our roundtable group included several Maryland transportation and healthcare experts. I've already, quickly introduced them. But again, we have Sarah Seitz, who is the Director of State Rural Office Health, Rural Office of Health, Rural Health. Noel Flaherty, who is the Director of Integrated Care Management at Calvert Health. Jonathan Dayton, who is the Executive Director of Maryland Rural Health. Tanya Nichols, who is the Deputy Director of Maryland Department of Transit Office Administration. Office of Local Transit Support, and Nancy Huggins, who is the program manager within the same office, MDOT MTA, Office of Local Transit Support, and John Dekluski, who is the executive director for TAM. And with that, before a program begins, there has to be some legislation. And there has been some movement in that on the state and federal level that does impact non-emergency medical transportation. And here's a brief listing of some of those, some of those legislations. And I was wondering if maybe we could have some of our folks talk about some of these programs and outline some of the pros and cons and consequences and where we are headed with that. Who would like to speak first?
I think John.
Good. You do the Stuart straw.
Good morning, everyone. Over the past 7 years, most particularly, and going beyond that, the primary focus of TAM in the General Assembly has always been addressing the issue of dialysis transportation, which is, of course, as Yolanda mentioned earlier, 3 times a week, really forever, until a kidney transplant can be found, or if they're not a candidate, simply for as long as they are able to survive. And of course, with improved medical technology, I think 20 years ago, the average life expectancy of someone starting on dialysis was measured in weeks. Now it is measured in years. And this, of course, is a good thing, but it does mean that you are now transporting someone hundreds of times per year, often at unusual times and places. And with more and more dialysis centers cropping up as the prevalence of end-stage renal disease increases and increases. So TAM's efforts have been focused around trying to provide the kind of resources that are necessary for the transit systems in Maryland to be able to adequately address this need. The need varies from county to county, but in some of them, their proportion of what we call demand response, which is our curb to curb service, over 50% of it is dedicated to dialysis transportation alone. And this, of course, is a very time consuming effort. So in the past, efforts have been made to partner with dialysis centers willingly or unwillingly and attempt to get them to share in the cost of the transportation of these people. These efforts were not crowned with success. However, in 2021, it did result in a budget language being included in MDOT's authorization, which did require them to undertake a study of the general state of non-emergency medical transportation in the state of Maryland. And if you haven't already been sent that study, we'll resend it after this meeting today. But amongst other things it shows is that the need is great, it is increasing, and the funding for it is simply not adequate to meet either current demand or future anticipated demand. I don't see listed on this bill, some of these are failures, but I will say that one of the successes that TAM has had in that just this past legislative session has been Senate Bill 838. While this bill addresses measures other than purely non-emergency medical transportation program, there is a funding stream called STAP, or the Statewide Specialized Transportation Access Program. This funds transit agencies across the state and is intended to provide transportation services for low and moderate income disabled persons and seniors. Funding for this had been flat for over 2 decades, and thanks to the efforts of TAM and many of our members assisting us, starting in FY25, this funding will begin to increase at an annual rate no less than the rate of inflation, which would be extremely helpful right about now. When we originally passed that bill, we were thinking, oh, that's a 3% increase, and not so much anymore. TAM's other efforts continue to be based around the idea that the main problem that our agencies are facing that we can see addressing is a resource problem. There simply are not enough vehicles to transport all of the people who need to be transported. There are not enough drivers for those vehicles. There are not enough dispatchers and mechanics. The problem as we see it primarily, and there are regulatory and systemic changes as well, is we're looking at it as a sense of a resource problem, although certainly a great deal can also be done in the field of coordination.
Director of Case Management. And I'm going to hand this off to John Hartline in just a minute, but I'm going to be his intro, I would say. So for House Bill 1234, I did testify on behalf of this bill. It provided funding for rural transportation. And one of the things that I really liked about this is that it had a case management component. So, and that's one of the successes of the programs that we've worked on, is having patients be communicating with not just the transportation folks, but also have somebody, either whether it be a community health worker, case manager, social worker, who kind of nudges them along to go on their transportation. So this was like amazing to me that this bill was proposed, and John can share the history behind the bill.
Good job.
Yes, I'm John Hartline. I'm chair of the Rural Maryland Council. A few of you may remember the summit of the Rural Maryland Council just a year ago. And at that summit, I was advocating for more funding for the rural areas. And as one of the legislators took me seriously, Seth Howard from Anne Arundel County, a Republican from Anne Arundel County, called me up on a Friday night just before the deadline for introducing legislation, and told me that if I had bullet points to him, he would introduce a bill that would support basically the format of our Wheels to Wellness program, which is non-emergency health transportation. And I put those bullet points together. I sent it to him, and thinking of all of our members and Tri-County Council executive directors, I suggested that the bill include funding for all 5 Tri-County councils. When I saw the bill was finally introduced, I was pleasantly surprised that every bullet point that I had given him was in that bill. So it was, I guess the last few years have been years of low probability events. Some would call it miracles. And our bill got into the legislature. And the main problem was that the bill, as it was introduced, we could not get, I'll be blunt, we couldn't get a single Democrat sponsor onto the bill. And that includes from my own Tri-County Council. So we could have potentially gotten the bill moved. And I discussed it with Charlotte, and she suggested that the way to get this bill or a similar bill would be to do roundtables and get a lot of people involved. And that's why we're here. This bill isn't exactly going to improve every situation, but it will definitely improve some situations. And Santo, I hate to tell you this, but you'll have to, as our workforce development head says, braid together more funds and provide more statistics in order to get these funds up and running and continue to come. But this bill is a good start to get funding to the rural areas and to move rural health transportation forward. There's in discussions with the bill, all of a sudden urban people got very interested in this bill. And finally, Charlotte, you mentioned that there was contingent funding on this. What was the number that
$1 million in the governor's supplemental number 5.
Right. So
It was contingent on passage of this bill.
right. So the governor stepped up and gave contingent funding of up to $1 million, which for our program would have really moved the needle. We've been spending maybe anywhere from $50,000 to $120,000 on this project every year, and it would have really moved the needle for the Tri-County Council. And here we are trying to move the needle and get
Sarah, would you like to say anything? John, can you pass the mic to Sarah?
Now stand up so you can see me better over here by the windows. So my name is Sarah Seitz. I am the director of the State Office of Rural Health. There are 50 of those in the United States. Ours here in Maryland is relatively small because we have a relatively small federally designated rural areas in Maryland. But as you all know, about 18, well, exactly 18 counties state designated as rural. And want to talk a little bit about the Affordable Care Act, of course, made healthcare generally more available across the United States. And then if we go on to the next slide, if you wanted, Yolanda, I can speak a little bit then to how that's progressing here in Maryland through the total cost of care model, and really this transition from volume-based healthcare to value-based. And I think that brings together even more the reason that we're looking to really reach everyone who needs transportation, whether it be in our rural areas. If we look at health outcomes, rural and Baltimore City look much alike. And so we'll see these transportation issues across. But here in Maryland, you can see state Medicaid, for instance, does include some requirements for its managed care organizations to cover transportation. And we see some funding that comes from Medicaid. You saw that in the passage of the Senate Bill 295 this year, and some more studying around how MEMS, our emergency medical management services systems, can look at transportation between facilities. And our total cost of care model, again, looking at how Maryland can be different. We have a unique system here in Maryland, our all payer model. And for Medicare, we are the only state in the nation that has a hospital global rate setting system through the Health Services Cost Review Commission, and really a focus on preventive care. And sometimes that means before the chronic disease like dialysis needs. It could mean those transportation for medically assisted treatment to get folks out of that chronic care system so that they can prevent issues as well. So that example that Yolanda gave of a 10-year-old in the dental visit and parents who need to work and don't have transportation. HSCRC and the work around total cost of care is really about keeping people out of our hospitals, because it is much higher quality of life out of the hospital, and it is higher quality of life for those folks and lower cost as well. And total cost of care really focused first on hospitals and them doing everything they could to lower cost, keep folks out of the hospital, so lowering their readmission rates. And then it has grown to include also primary care. And we see that in the Maryland Primary Care Program, which also receives funding through the total cost of care model. So that, again, the more we do to keep folks out of hospitals, treated in their primary care settings, in their communities, the better. And that now includes, for instance, heart payment through the Maryland Primary Care Program that includes transportation coverage. So we're seeing funding, just as we've said, coming from many different directions in order to keep folks in their communities and getting to primary care and those chronic disease appointments that keep them having a higher quality of life and out of hospital situations, and acute emergencies growing. But we see there are gaps. Just in the Delmarva Community Services introduction, we continue to have these gaps, and we have such a variety of ways, including also our local health departments, for instance, who are doing direct transportation services as well to a wide variety of clients and residents also. So this slide talks about our Medicaid, our total cost of care, also then just specialized disease conditions and grants. and silos. Medicaid feels a different world to someone like me in Office of Population Health Improvement, which is separate from maternal and child health, separate from cancer prevention and control. But we have a lot of components of funding available through these aspects of health as well. Yolanda, did we cover what you were thinking there?
I think we did it. Does anyone else want to?
I have just a question. We've been providing senior services for many years and services for people with disabilities. Usually people with disabilities could get certain things covered, not always the seniors. And we find that dental care and the need of many rural seniors having horrific dental problems. And yet there's no funding, a special funding, or any type of funding that helps them. And it's really, it's a tragedy at times, because if they can't eat, if they don't have any teeth, it's very hard for them to eat. And
Definitely a topic that pops up with stories of tragedy around that. We have cases in Maryland of young children with leading to death due to oral health issues. And it's one that continues to come to the table. But I think it's definitely worth noting in these conversations, and why John used that term of non-emergency health transportation, because this isn't just somatic health, but also oral health, behavioral health. When we talk about the medications for opioid use disorder, it is such a wide range of body, mind that we need this transportation connections for. So I think that's a great point, and somewhere that the Office of Oral Health would raise their fists. And I hear, for instance, recently on the Area Health Education Center in Western Maryland with their tooth fairy program, for instance, and their dentist saying, we need to hear more. So I think it definitely makes it to the list here of an area of need.
Yeah, so just in reference to oral health. Oh. So my name is Sharon Smith, and I'm Director of Transportation for Partners in Care, Maryland, and we're based in Pasadena. But just from previous issues, what we're finding is that just globally, people view oral health different than physical health. So if you have an issue, you'll go to the doctor, but if it comes to oral health, there's stigma. So oh, well, I go to the dentist and they want to take a bunch of x-rays and they don't really need to take. So they don't really feel like they need to go until the situation has gotten dire. And so I used to work with Head Start, and one of the programs that they implemented in Head Start is one of the requirements is that they required all the children, just like everybody else, to have 2 well dental visits a year, trying to change that paradigm shift, equalizing oral health with physical health. And so with some of our older adults, it hasn't gotten that, but from kids going up, now we're making it more of an issue. But we do have a lot of members that we take to dental appointments, and because the disease is such that they're going multiple times to the dentist. So it really is an ongoing problem.
This is a good time to see, is there anybody who has commented in the chat box, or is there anybody in the remotely who would like to comment on this?
Hi, this is Delegate Robin Lewis. Can you hear me?
Yes.
Hi, thank you guys for this great meeting. I entered a link in the chat for those who are able to see the chat, but we did pass legislation this session, House Bill 6, that passed into law, that expands access to dental coverage for all adults covered by Medicaid in the state of Maryland.
I'm sorry, but could you repeat that? I think we lost you at House Bill 6.
It's in the chat.
Okay.
If you can't hear me clearly, I did include the link. House Bill 6, which passed into law, expands dental coverage for dental services for all adults covered by Medicaid in the state of Maryland. This, we hope, will address the enormous unmet need for dental care among adults. And one of the participants in the meeting referred just now to the great need among seniors for dental care. For those who are covered by Medicaid, adults covered by Medicaid, we hope this will begin to meet that need. And I included a link to the bill in the chat to make it a little easier. The bill becomes effective on January 1st, 2023. So we're doing what we can to make sure that people have the coverage they need. Thanks for giving me a chance to speak.
Thank you. Is there anybody else in the remotely who would like to comment? Okay, hearing none. At the same time, while our healthcare community has been working on trying to provide non-emergency medical transportation, we cannot be silent about the efforts by the Office of Local Transit Services and Maryland Transit Administration. And we're here again. I'm pleased to introduce Tanya Nichols, Nancy Huggins, and John Dekluski, who would represent that. Like to see it. So Tanya, Nancy, and John, when you see this list of programs, is there anything that jumps out at you about some of of these programs? And can you describe some of these programs and how they address non-emergency medical transportations, the pros and cons and challenges?
I suppose I'm up.
Oh, hold on, Tanya.
Hi, I'm Tanya Nichols. I am the Deputy Director for the Office of Local Transport at MDOT-MTA. So we manage all of the formula funds. So the federal government in the state of Maryland passes through to the state of Maryland. We're very unique in that aspect that Maryland actually manages all of the federal FTA formula funds. And they come in different numbers, and I haven't even mastered the numbers, and I've been in this for a while, but 53 funds that are used for fixed route and deviated fixed route and paratransit. And we support the locally operated transit systems called LOTS on an annual basis with operating and capital funds that are distributed through our office. And as everybody knows, or if you don't, you're going to learn today that the IIJA, spell that out for me. I can never remember that. The
Infrastructure Investment and Jobs Act.
There you go, John. I just call it the IIJA and remember the meaning behind it. The IIJA has initiated a much larger pot of formula funds to be passed down in the state. And we are taking this opportunity at the Maryland Transit Administration to do a methodology change so that each county or locally operated transit system, including the MTA, will have a fair share based on their ridership and their needs. Because actually, John may know where that original methodology came from. So it's been kind of standard for more than a decade. So we're going to take this opportunity now. So all of the locally operated transit systems will have an opportunity to look at the new methodology and make comment. We're hoping that will be out soon. So with that being said, we have the formula money. We have SSTAP, which we talked about, which is also through our office. There's also 5310 funding, and I'm going to turn that over to Nancy Huggins because she is the master at that. So she can answer all your questions and then some to go to her. But in addition to that, I also want to bring to the attention discretionary funds. Many of our locally operated transit systems can apply for discretionary funds through the MTA or direct sometimes for this additional funding that is starting to drop from the Department of Transportation or the Federal Transit Administration. Mobility. IIJA, for example, one just dropped this week for the enhancement of technology and mobility. We are going to keep an eye out and pass on, but some of them have no matches or small matches. And that's incredible for a transit agency just to connect systems and hospital systems and social services systems to your transit system to allow you to efficiently check free fares or no fares through a social services system, a direct, efficient way to run a transit system in a more effective means. And hopefully with that, you get to reach more people. So that's all I have. If anybody has any questions, I would be happy to answer them, and then I'll turn it over to Nancy.
Okay, hearing none, I'm Nancy Huggins. I'm 5310 Human Service Transportation. And the 5310 grant is a federal grant, and it is for our entire state, with the exception of Montgomery and Prince George's. They actually go through, their grant cycle goes through the Metropolitan Washington Council of Governments. So the 5310 grant is actually open for nonprofits. You must be a 501c3 organization. The application is now open, actually. We had a meeting last week at the Transportation Association of Maryland meeting on the entire grant program. It is on the TAM website, Transportation Association of Maryland. So this is both for operating dollars to help nonprofits transport their folks by paying drivers, admin, staff, et cetera, to get their constituents to medical appointments, senior centers, et cetera, things like that. So it is operating dollars. There is a 50% match required. There's also capital dollars. That's a 20% match, and that's to purchase vehicles and other capital items that someone might need. So that is the 5310 grant. It is open. You're more than welcome to take a peek at it on the Transportation Association of Maryland website. You would go to resources and then go to our page called the Office of Local Transit Support. So again, it's open for nonprofit agencies. A second program that I manage is called Senior Rides. That's state funded. That is open to just about any agency. It'd be a nonprofit, a governmental agency, et cetera, that manages a volunteer driver program. And the uniqueness about volunteer driver programs is that they take folks to not only doctor's appointments, but the non-emergency medical, as well as to the hairdresser, entertainment, worlds like that. So that's not a lot of money in the state of Maryland. Right now, it's $187,000 annually. I have about 10 agencies, 9 or 10 agencies that take advantage of those funds. It is statewide, including Montgomery and Prince George's. I do have some that are towards the west part, but I think it's like Frederick. So basically, so that grant opportunity will open up in January, and that is an annual grant opportunity. So I'm hoping that John will help us get more money through the state for that very important Senior Rides volunteer driver program. So thank you. I'll be happy to answer any questions.
And one thing that I would mention about the Senior Rides program, which is indeed increasing that fund for all grantees is a major priority for TAM in the coming session, is that it's not only a relatively small amount of money when you consider the total amount spent on transportation in Maryland, but dollar for dollar, it's probably the most efficient and effective way of transporting the people that it does, because it uses volunteer drivers. So it's absolutely one of the best programs the state has developed, and certainly one in great need of, I think, reevaluation and reinforcing. One thing I wanted to mention here is one of the things you don't see here on this list is Medicaid funding. A lot of people in this state, including some of our, the most important people in Annapolis, when they hear non-emergency medical transportation, they think, oh, that's Medicaid. But only 4, I believe at this point, of the locally operated transit systems in Maryland out of over 20 actually provide transportation service. Of transit agencies in Maryland are not doing Medicaid transportation. Now, they're transporting a lot of people for non-emergency medical transportation, but they're not doing it with Medicaid dollars. They're doing it with these. They're doing it with a lot of local funding. They're doing it through other discretionary grants that aren't mentioned there. And they're really transporting all of the people in many cases that Medicaid won't transport. So one of the things I'd like us all to remember during this is that non-emergency Non-emergency medical transportation, say that 10 times fast, is not just a Medicaid issue. That's half of the issue. There's a lot of non-emergency medical transportation that goes on completely outside of that. There's a public area, there's a nonprofit area, there's a private area. How much of this is taken on by people and family members trying to help out? And we all know how much changing demographics have altered the relatives, but not just a Medicaid issue. And it's something that I think is very important for us to remember for the rest of these roundtables.
I would like to share on that note a personal experience of what non-emergency medical transportation means to me. When I was 17 on the day of my graduation of high school, my mother had a massive stroke. I was the youngest and all of my brothers and sisters were gone. And I was left with the responsibility of a 17-year-old girl. My mom was put into a facility that helped her recover. She was a fully independent woman. She was 48, a fully independent woman who was now completely disabled and relied on a teenage girl. And I can tell you, and she didn't qualify, even with the Social Security, she was just above the Medicaid mark. And I the resources. So I had to put my life on hold, limited, to assist my mom into recovering. And by the time I got to my 20s, we lived in Anne Arundel County. I grew up in Anne Arundel County. And by the time I got to my 20s, I had to go to work. I didn't get to go to college, but I ultimately had to go to work and support and grow up. And we used the Maryland Transit Administration bus service. But we even found that to be a challenge because she did have a limp and she did have disabilities and she still didn't qualify for Medicaid. And I can't stress that enough, that the line of Medicaid, it's just so small and there's still such a large need. And as our society moves forward, where many parents, we don't have grandma and mom and ourselves and our children all living in the same home, maybe that tradition has ended. We still have young people having to step up and find the resource parents, and we have to be in the workforce because of whatever happens today. So on a personal note, this is very, very important to me. And I hope that we can bring the stigma. Medicaid covers all of the need, because I really, really want to express that it doesn't.
Thank you.
You probably hear me. Just quick question. Maybe John, you have the answer or something else. What do volunteer driver numbers look like around the state, around the county? Do you have a good sense of, are we consistently getting volunteers? Or is that still part of the problem?
So I can report on that. I did not bring my report that I give to the governor every year. I did not bring my report. I guess I should have. But it is increasing. The getting volunteer drivers as to that, because is one of our grantees for the senior ride, but they are transporting more and more people. Of course, there was the downside because of the COVID time, where a lot of the senior ride programs did transition to things like food and medical supplies to their constituents. I had one group in Southern Maryland that would call every week each one of their clients to make sure that everything was okay. So they did do the transition. So it is becoming a little slow return, but I did see last year that it was making a return. So I don't have the number off the top of my head as to what the number of folks that are being transported, but it is increasing, and it does every single year as folks age. So, I mean, because I can't keep numbers in my head, but hopefully that gives you a little bit of idea. And Sharon, you might want to address the your program specifically.
So Partners in Care provides, our mission is to assist older adults to be able to remain in their homes for as long as possible and stay engaged in the community. And we do that through transportation, handyman services, member care services. But what we're finding is as soon as someone becomes a member, our call is, when can I get a ride? And so, and they're, they're going to the same places that you and I go to, their doctor's appointments, to the grocery store, to get their hair done every once in a while, that kind of thing. And it is a real challenge to get volunteers. COVID did the average volunteer with Partners in Care is about 72. Well, as you can imagine, many of those volunteers have either healthcare issues themselves, or they have a partner who has healthcare issues. And so a lot of the people backed off because they said, hey, my wife is a cancer survivor and she has some autoimmune issues. And so I'm really nervous about driving. So what we did was we stopped driving for about 2 weeks. And then we came back. And so we had measures in place, like the driver wore a mask, the passenger sat in the back seat, they wore a mask. Some drivers say, I lowered my windows a little bit, hand sanitizers, the whole 9 yards. But because COVID, people still needed to go. Even though they did, doctors were doing the Zoom visits, as soon as they started seeing people back in their offices, the numbers just skyrocketed. We encourage people to have a plan B. They said, well, you are my plan A, B, and C. And so in some cases, we take people, for infusions a couple of times a month, and this is life sustaining. And other people, they call us every single week. We ask that they give us 7 days notice, and they call us every single week. And they may say, Sharon, I'm calling in my rides for the month of October. And so someone mentioned earlier, we don't have the close-knit network that we once upon a time, where grandma lived with you, auntie lived with you. So when I ask folks, sometimes if for some reason we can't do a ride, I say, well, what about a neighbor or a friend or someone at your church? And they say, well, I don't have anybody. And so you say to yourself, well, you don't have anybody? I don't have anybody. And so it's this stuff is real, folks. And it's a huge challenge. Sometimes we can do some referrals. I had a lady who called, she needed an epidural. And they said, well, you have to have someone who will come in with you and then go home with you. And we don't go to that level, but she was crying on the phone. She's like, what am I going to do? And I was at the point, I was about to say, well, can you switch it till Saturday? Because then I can come and take you. But I was able to do, there are some senior programs where they're paid. So I was able to connect her with a service where she could get that done. But she said, what am I to do? So these are some of the real issues that older adults are facing on a regular basis. And, again, we're trying everything we can to get more volunteer drivers. And, but I tell you, the ones that we do have, they are soldiers. Sometimes they'll take 2 rides. They'll call, they say, well, Sharon, I can do this one in the morning. I can do this one in the afternoon. And I'm like, God bless you. And some of them, because they might select 10 rides. So, they are worth their weight in gold and more. So when you can get good volunteers, boy, you've got something.
Question for that. Would pay help with that at all? That may seem like a dumb question, but if there was a monetary ability to support these individuals,
we offer our volunteers gas reimbursement, and we do it twice a year. And we let them know that's based on funding. The vast majority decline it. When the gas prices started to soar, we were really worried because we were like, gosh, some of our rides may be 50 or 60 miles. And we went to the county and we were able to get a small grant of $20,000. And we divided that among all of our drivers, and some checks are a little bigger than others. 98% of those people returned the checks because they say, I don't do this for the money, and our program is like a time banking system. So for every hour that you volunteer, you get an hour in the time bank. So down the road, when they need, a light bulb change or some, changing the toilets or grab bars or those kinds of things, they say, I'm building on. So when I get to a point when I need it, that's why, and I'm telling these people they're jewels. And, but we're trying to reach out to a younger, because our folks are getting older and they're aging out of the program. And so with COVID, though, we've had some people who are working from home, and so they have a little bit more flexibility. So we have a 25-year-old Marine. She does rides, and we have some other folks who have flexibility. They say, well, Sharon, I can do rides on clock. So we take whatever we can get.
So with regards to the senior ride program, there are some agencies that do have some paid drivers. The bulk of it is volunteer drivers. Many of these senior ride programs go to great extent in training their volunteers for a variety of things. Not only for using CarFit to figure out how your car works. Is it in good shape? All the way to, sexual harassment training. And I mean, they do go to great lengths to make sure that their volunteers are trained. Like I said, I only have about maybe 8 to 10 agencies any given year that takes the funding. A lot of the times the funding is not a lot, but they use what to give me now later when I get back to my desk. I'll be more than happy to let you know what the amount of volunteers are versus the number of folks that are transported. Because I do have that. I looked on my phone. I don't have it because I sent it to Tanya for review and it didn't pop up on my phone. Otherwise, I would have been more than happy to share it. So. All right.
And we do background checks on everybody, on the drivers, on the members, because we want people to feel comfortable and to feel safe. And if older adults, sometimes, they get groceries and maybe they can't take them into the house. And so sometimes our members will in and they say, well, Miss Jones, we have to sometimes back our volunteers up a little bit because they're putting the groceries away. And so, but you have one volunteer who does that. Well, then the next volunteer doesn't do that. And so they may call and say, well, don't sit on. Help me take my groceries out of the car. And Mary, she took them inside and she put them away for me and that kind of thing. But yeah, we try to make sure everybody is as safe as possible.
I would like to point out that at one time or another, both Sharon and I were volunteer drivers for another agency. So we got the extensive training, and they're very sophisticated. Calls come in for, we want to ride on this particular day. The agency sends out the blast for all the drivers and you get to pick and choose what time and where you want to go. I didn't even do a one-way. I did a one-way from Columbia to Silver Spring, Maryland for entertainment purposes. So, so it's very flexible for, if you're interested in being a volunteer driver, there's a lot of need out there.
Absolutely.
So, and you can do after a week. So there's always that. So I have lists. Reach out to me.
Nancy, how long has when was the last time that Senior Rides program received a bump in funding? It seems like a very effective program.
FY 2014.
Thank you. That's what I was going to say.
So it has not kept up with inflation or anything like that.
No, John, do you remember when it was appropriated for like 400?
So the statutory maximum for the program is $500,000. And I believe for the 2021 report, the amount appropriated was $187,000. The amount sufficient to fully fund all of the programs, and the MTA did say that all of the programs should be fully funded, I believe was about $315,000.
But yes, the actual staff that goes out there to get the volunteers, to make sure the volunteers are matched up, to make sure that all the training and all the background checks and all of that is. So that's pretty much. And I do want to point out that these programs, both the 5310 program and the senior ride programs, are vetted not only by our department, but we have a committee from the state coordinating committee for human service transportation. I get that right, Scott? So we have a committee that comes from a variety of different state government agencies that actually review and go through, and our leader here has been on it as well. Yolanda has done both the 5310 and the senior ride. Is that correct, Yolanda? Both? Different agencies that serve on the community for reviewing for everything.
Okay. Are there any other comments? Maybe someone from remotely would like to comment? All right. So that's how we got here. And it seems like we have two groups, two industries, two groups who are both doing their best to help the patients. But I think I'm hearing that there's some significant gaps in in order to address the problems. And in fact, the working poor, these affect, it creates, people who are just groups that are just not being served. And I'm also hearing that, for certain populations with chronic illnesses, these gaps can be catastrophic. I'm just going to ask our group, would anyone comment on that?
I'm going to grab the microphone just for a second. And that the Southern Maryland Veterans Committee has been, they've actually completed their project of getting a CBOC into the Southern Maryland area. But they've been looking for something additional. And one thing that they have been very concerned about is there is health transportation for veterans, but they've asked us to include veterans. So on healthcare, you have, the Medicare, you have the total care, and there's a substantial amount of money for veterans care. But what we found is that the transportation problems of getting people are missed. And I'm just going to relate one quick thing that happened at the Tri-County Council. When we started doing Wheels to Wellness, we started getting calls from veterans who were having trouble getting transportation, even though that it was actually being paid for by the federal government. And it turns out that if you're a veteran and you check the box that says you need transportation, the process of getting approval and in their transportation program takes between 90 and 120 days. And so if you have an immediate need, that doesn't exactly solve your problem. And we got a call on, it was on Friday before Easter, of a veteran that had a appointment to, he was having surgery for a tumor, said, I don't have any transportation. And when he called the Veterans Administration and they referred him around, they said, well, you checked off the box that says you have transportation. And he said, that was 3 years ago. I don't have any transportation now. They said, well, we can reschedule your surgery when you get qualified, or you have to find transportation. So I would put healthcare on the left-hand side of something is veterans healthcare. And on the right-hand side, I would say that they definitely have a transportation gap. They do have money, but it takes time, a lot of time, to get qualified to take advantage of that transportation. And I just, it's the same need, but it's just as important. And there's a lot of aging veterans right now. Thank you.
And just a quick thought that I had is that and I know the care field have recognized this as well. There's a particular insanity in someone having the funding for a procedure for which the hospital or Medicare provider can be reimbursed over $1,000, and the person never gets there because there's no way for them to get a ride that ends up costing $30.
And I would like to add that with transportation in our area in Southern Maryland, paratransit is taking off dramatically, but most of it is to the dialysis centers. And that's paratransit is supposed to serve all of the needs for our disabled community, from medical to include shopping to getting your hair done. But if most of it's going for dialysis, that's that many of these patients need special help, getting into the building. They need to make sure that they have the wheelchair securement, that the wheelchair, they have wheelchairs, we have to accommodate the equipment. And that takes a specialized training as well, that may not necessarily be easy for, for many. Anyone else have any other comments?
Yolanda, you're talking about general paratransit versus the ADA paratransit. Okay. This one, because it can go ADA as the 3/4 of a mile.
Correct.
On more than one occasion, we've reached out to, because we have some dialysis patients, not a lot, but on more than one occasion, we reached out to dialysis centers and say, hey, our members sometimes are your patients and we have vehicles. Is there way? Well, yeah, you can bring them. We said, well, are you interested in a financial relationship? They said, oh, no. And we had one gentleman we were taking to dialysis. He lived in Serena Park, and he was going all the way down to Odenton for dialysis. And if with some dialysis centers, they say, okay, pick him up at 3:00. And at 4:00, he's done, because they couldn't get him in the chair at a certain time. And so, the driver's just sitting out there for another hour. And so finally I said, well, why are you going all the way to Odenton? There's one like right down the street in Pasadena. And he said, well, I require Horia lift. I said, well, did you have your social worker talk to and he said, well, no. I said, well, do you mind if I call someone down there? And I won't give any names. And so I called and I said, do you use a Horia lift? She said, sure. I said, well, I have someone who's going all the way to Odenton. Can he maybe get over here? Can you call them? You guys talk? And in 3 weeks, he was going to goes all the way over to Odenton. So sometimes it's just somebody intervening, but yeah, those dialysis centers, they're not interested in paying for anything. That's for sure.
We are getting back to VA transportation, veterans transportation. I believe it's still an issue that the VA, we have a clinic right here in Cambridge, but they don't take anybody door to door. They only take them to Route 50. So we're called upon to be there upon their return to pick them up on Route 50 to take them back home. And so the VA van will not get off of 50. They won't come off of 50. They go straight down, up and down 50 to go to Baltimore for the VA hospital. That's been a problem for us over the years, is being there when this veteran is dropped off on 50 somewhere. Usually nowadays it's been 404 and 50, but that's the veterans red and white and blue bus van will not go off of 50.
Wow.
And the most veterans need door to door.
Do they just drop them? I mean, they take them to Walmart, or they just drop them on the side of the road?
They just leave them up, on 50.
Wow.
Oh my God.
Yeah. At least at a bus stop.
What?
Sarah wanted to say something.
Mention it, I think, Sharon, is that correct? Mentioning, we've talked about workforce shortage around drivers, but the documentation and increase in need around community health workers for these purposes. It's so hard to know who to call, when to call. If you drop me off on 50,
Right.
that's, I'd be calling my fifth grader. So how am I going to get further? But I think this all connects then to workforce and the people, the connectors, the bridges, because yes, if you're in your 70s, if you're disabled in your 40s, if you don't have a master's degree plus 3 doctorates, these systems can be very difficult.
If I may dovetail on the dialysis issue, I am new to Shore Transit, but I do know we have not asked about financial connections, but what I do understand is dialysis centers in our region are not even having coordination. If we could maximize our resources and a coordinated entity with the healthcare systems that serve our communities. We could be a force multiplier with our available resources by connecting seat times and getting together as a round table, if you will. Not even a round table. Hurricane Sandy, I was part of an emergency management group that came up and down the East Coast, and I recall how we triaged victims for Long Island hospitals, how that was a part of it. And it's the same thing. It's an everyday conversation, and it's a board of people who are sharing seat times and availabilities, their staff times, and what we can do to maximize our buses and the people who need specific wheelchair access and those who don't. And I know that that's a daunting task, but trying to find other funding sources, and a whole lot better than saying no when you really do know what that means. Because when I say no, we can't take you, I know exactly what that looks like. And if I keep saying no for about 3 weeks, I don't have to say no to you anymore. And that really matters. And every decision we make, from the people who are taking calls and who are dispatching and the drivers transporting, these people know has a face. So it's tough, and it's being from healthcare and dropping back to transit. I can tell you that it doesn't look any different. It doesn't look any different for a driver who can't help or who will help even when you're not supposed to. These people care because, surprisingly enough, we're not paying them $1 million. And they deal with so communication and connection in an organized manner in the way that other healthcare and public health entities do it in a disaster situation, because that's what this is. This is a disaster situation where we have a greater need than any reasonable resource we have. We have no money, we have no drivers, and we have far more demand than we can. Treat it like an emergency, act like an emergency, and act like a cohesive team. And that's how we're going to close some of the gaps. Thank you.
You're here.
And I think the phrase that you said is that if you don't hear, if you say no after 3 weeks, you won't hear from them anymore. That's what we're talking about. We're talking about life and death situations. I will say that regarding bridging the healthcare transportation gap, as John Hartline mentioned, we work very closely with the case managers from Cal Health, actually, and and St. Mary's and Charles University of Maryland Charles Regional Medical Center. Exactly, it's our 3 county hospitals that we're working with. The hospitals actually identify the patients who do need the rides, and then we coordinate with the human service providers who are well trained in transportation for disabled, and to get them to their appointments and follow up. And that does seem to help. And I just want to see.
Yeah. So we're a small program, but we are able to change the seats. But it can take time, multiple phone calls so that we can coordinate the transport with when we can get the most number of people into dialysis. But that's, versus on the healthcare side, which I think most case managers would be more than happy to do, because other and giving people access to the hospital 3 times a week or more, or if they have an even worse outcome. So I think it's a good program. It would need to be institutionalized or made, able to apply to bigger systems other than our little community where we know most of our patients in the end and our drivers.
It also sounds like an opportunity for technology, quite honestly. I mean, we live in a time where, aggregating data is very common, especially aggregating large amounts of data. And it sounds, at least from a HIPAA standpoint, open dialysis appointments wouldn't be a problem in terms of getting that information from the provider's website. Obviously, filled dialysis appointments would be a problem. But, so I feel like we have some of the tools that might remedy some of this, but this in regards to, the blueprint coming out. I think it behooves us as a group to come up with one solution, not a solution based on each county. And that way, when we talk about aggregating data, we can do it in a way that most conveniently and efficiently shares that data. So when we're talking about transporting someone from St. Mary's County to DC, it's not a single point of failure as far as, well, Jack was out today, and if had Jack answered that phone call, then, well, it would have happened. But, well, Jack, had a birthday party or something. And, so I think that's where we have an opportunity.
I agree with that, but I'll put in a statement for maybe the opposite, or why local is important. And from that perspective, the council, we're not HIPAA people, so we can't look at any of that information. And so we had to sign a business services agreement with each hospital. The transportation software house that is scheduling our rides had to sign a BAA with the hospital. And then the hospitals had to sign agreements with each other. So to handle 3 hospitals, we had 8 signatures on one document for each hospital. That's 24 signatures with 24 sets of lawyers looking at that information. If I were to add Southern Maryland Hospital, which I would love to do in Prince George's County, then I would need, 9 signatures, and I would need it from 4 hospitals, and it goes up exponentially. So we've chosen to work at the local level because hospitals have to be solved. It's exponentially too large for us to solve. Whatever the solution is, the state comes up with a global solution. It's got to keep the patient information in the hospital and the transportation information outside of the hospital, so we can provide the rides without actually knowing the conditions that the patients are having. So we've solved it for our particular area. From a paperwork perspective, now it's money, but I can't imagine going into a more urban area and having to get 25 hospitals to agree on anything, because it would never get past any of the lawyers.
My comment may verge on but one thing that you definitely made me think of, Andrew, is we have some buy-in from certainly public health, transportation, hospitals, but for instance, a dialysis center that is not connected, some buy-in probably needs to be part of that strategy in order to get that coordination. And also, I'm liking the idea of technology. We do have one health information exchange in Maryland, and we're doing quite a bit more around social determinants of health, and potential. And CRISP, our HIE, is doing more around social determinants of health, one of which is definitely transportation. And my hope is that that's being a lot more timely, and that information is updated on a regular basis by caregivers than maybe what John's example of Veterans Administration might be. So some thoughts that we stress parts. Those are things that I was hearing.
Any other comments?
So remember how I told you to look for discretionary grant opportunities? As I said before, one did come out. It's called SMART. It's around technology and mobility. And it speaks of exactly what we're speaking here now, about finding innovative solutions to connect hospitals and social services to our transit system to make an effective, efficient way to provide mobility services. I actually have the NOFA right here, if anybody wants to take a peek. It's all highlighted. There's no match on it. And these are the kind of things that maybe we can start thinking about. It's a planning grant. So it's really doing all the feasibility studies and grabbing the demographics and seeing if it can be an effective way. And this might be a great tool to find. So I will pass around after I find my paper clip and he gives me back the one paper. And you can also reach out to me. I don't have a business card yet. I'm too new, but I'm going to get there, I promise. But you can also reach out to me and I can send you an email. I drew up exactly what the process is and some of the things I can give you advice on how to go after it. It does have to be a government entity or a transit authority. But, you know, I'm all about teaming up in partnership, which is a great way to do this. And this might be the means to find the funding we need to at least kick off what direction we're going.
Could you provide your information in the chat, please?
Can you provide the information in the chat?
I can.
Okay, we'll get that to you. Any other comments?
Hi, I have a question. This is Darlene Valentine. I'm the Patient Access Manager at Family Health Care in Hagerstown, or in Washington County. You were saying that there were a senior ride program, but it only goes to Frederick. Do you know of any transportation programs in Washington County that is maybe volunteered, or we have our health department, but patients have to fill out an application, they have to be approved, they have to give a 3-day notice. Same with the CDC, the Community Action Council, sorry. They also have to fill out applications, and it's only for a certain group of people. So we're a nonprofit. We have our own transportation program that we got a grant for. So we bought a van, we go pick up our patients who qualify and bring them to their appointments and take them home. But if someone needs to go to Baltimore, Johns Hopkins, or University of Maryland, or any place like that, they have no rides. They have no way to get there. So do you know of any programs in Washington County area?
Yeah, that would be senior line. John.
Yeah, Nancy Huggins again with M.MTA Senior Ride Program. I do not have any agencies for the Senior Ride Program in Washington County. You mentioned the Washington County CAC. They are a 5310 recipient. And they have a very robust program, as you probably well know. But at this time, I don't have anyone for the senior ride. I will be releasing that grant, state grant, in January. As I have only 3, I'm hoping you might want to also take a look at the 5310 grant opportunity that you can find it on the taminc.org. You can go taminc.org and scroll over to where you see resources and then down to the Office of Local Transit Support, and you hover over that and you'll see the 5310 grant. My information is on that. You're more than welcome to give me a shout. Does that help?
Yes, thank you very much.
I'd like to make a comment if possible. Can I go ahead?
Please.
Yeah. So my name is Dr. Lorena DeLeon. I am the Senior Director of Population Health for Maryland Physicians Care, for the 3rd largest managed care organization in the state of Maryland for Medicaid. We have about 250,000 members statewide. I want to commend you for pulling this team together. This is something that we face every day. Most of our members have transportation issues, and it has been a complete nightmare for our team to have to coordinate transportation across the state. We find ourselves in a situation where every county has their own grant manager, and the rules are different for every county. And many of our members don't qualify. Much like what Darlene was mentioning, we spend countless of hours trying to download forms, send and get approval from physicians to coordinate services. And we have nightmare stories of members that have been left on curbs countless of times. And so I really appreciate the effort that's being put here. We are actually looking, and one of our colleagues is on the call as well from Allegheny County, at opportunities to use technology and to centralize resources. We've been recently working with a company called TripSpark that actually serves, I believe, as the platform for the MTA and trying to connect different points of access for Medicaid, including working with our 4 owners, which are UPMC, Meritus Health, Holy Cross, and St. Agnes. All 4 health systems are facing massive transportation issues as well. So anything that we can do to help or to be part of this group, please include us.
We sure will. We will be in the western part of the state in 1 month, and we will continue this conversation.
Yeah, we're statewide, so this affects us across our entire population.
Okay, well, it is now 11:32, and we were going to the station. We will be back here in about 1 hour. So I invite everybody to, the lunch is outside here. You can eat downstairs or in here, and we'll be back in 1 hour. We are about ready to start. This is half of our non-emergency transportation roundtable 1. And again, just to ground us in what we were trying to do here, we had a very good conversation in part 1, but just to circle back to what we're trying to do, here's a clip from somebody.
Hi, my name is Erin Farley, and I work at Calvert Health Medical Center and have the privilege of being in charge of their community wellness program. Been a nurse for a very long time, 25 plus years. And I found in the past year that I got in a bit of a pickle with caring for my parents. And as I already knew in our community and in the state of Maryland that transportation is a big issue, being part of community wellness, that wasn't something that was new to me, but it becomes a different issue when it's your own personal problem. We got into a situation where my father was unwell and my dad doesn't get she's not mentally very intact, but she can get around pretty good. Together, they're quite codependent. They do really good doing things together. And actually, when you separate them, it makes things much worse. As he became ill, living in a little bit more of a rural community, I don't have extra people and family and friends and all kinds of people to help get them back and forth from appointments. And when he got very sick, he certainly couldn't be driving. It was not safe. And luckily, I was able to access our local Wheels to Wellness program. So at least minimally 2 to 3 days a week, they were able to get transportation to and from their appointments. And I think that it touched me in the fact that a lot of programs are geared towards underserved or individuals who financially maybe don't have a car. This is a lot different when it is a matter of making a decision, looking at the calendar and making a decision. Okay, this week, what specialist does my dad get to see or not get to see? Or what services is he going to get or not get? Because there's no way I can walk away from my job every day to get them to and from their appointments. And I think that's really the crux of the issue that I see, is that people really are sitting here having to pick and choose what appointments they're getting to and what appointments they're not getting to. And let's be honest, I'm a nurse picking and choosing. What happens when it's just your average individual picking and choosing which appointments they're going to go to and not go to? So, you know, this all equates to a unhealthy community and people who are not managing their chronic conditions. Although this was an acute situation for my dad, he does have chronic issues as well. So I can see how this is a big issue in our community. But for me, I can only speak to how important it was for us not just to have a ride for mom and dad. While dad was wheelchair bound, the wheelchair van came and took him in the van, and they were gracious, and my mom got to go every time. They were lovely to them. My parents could not have said anything nicer about their experience. And that's part of it. People need to feel that the right person, and I needed to feel that I could trust who was picking my mom and dad up and taking them back and forth. And knowing that if they didn't have something they needed, they could reach out and somebody would help them. And they wouldn't just be forgotten and sitting somewhere. I think the other thing that I found was very important was being an ER nurse for many years, is that the right person was transporting them with the right qualifications. And what does that mean to me? Is that was the same fabulous people who understood the dynamics of their situation, of my mom not having a good memory, my dad not being able to move well. And quite frankly, we didn't want him in the wheelchair anymore. We wanted him moving and walking. So we told them, don't show up with the wheelchair van, make him walk with his walker. Mm-hmm. So I felt like we were a team. We were all on the same page that we needed to get them to their appointments back and forth. And if they needed to reach out, if there was an issue, they would reach out. So sometimes I know from working emergency medicine that we often, had parameters and protocols said it had to be this category of transport, but there needs to be another whole category for people who are not going hospital to hospital. They're not going hospital to nursing home. This is people at home who simply should not be driving or don't have someone to take them. Because quite honestly, if this didn't happen and my dad wanted to go to one of his appointments, he would have gotten in the car and drove. Mm-hmm. And that's not a safe thing for anybody in the community when somebody's unsafe to drive. But every day I would get people in the hospital in the emergency room who drove themselves, and they should have never been driving a car because of where they were medically speaking. So I think it's really safe to say that this program that I got to tap into was a lifesaver for me, a lifesaver for my family. My dad's 84. He had all his procedures. He is thriving and back driving and back on the golf course. So I just, really appreciative and feel like this is definitely something that we all have to work together to make transportation a better system, better options, and better things to support anybody, no matter what your economic level is, to be able to have a safe transport back and forth to those appointments.
All right. We worked on earlier the poll questions, and I'm going to ask Jason if we could have the first poll question we have. The first question is, what region do you represent? If everyone could get to their Polling Everywhere app.
There's two options on the top of the slide. You can respond. So you can either log into pollev.com / and then there's our name, or you can text. So there's two options.
And while you guys are doing that, I'll take this time to introduce myself. My name is Leslie Coker, and I'm with Maryland.
Oh, so I'm Leslie. I'm sorry. I was going to introduce you later.
No, it's okay, because this is later. So we only have about till 2 o'clock to do this part, and we wanted to leave some time at the end. And so my name is Leslie Coker, and I am with the Maryland Acres program. And Maryland Acres program is with the Maryland Department of Agriculture, and they have a contract vehicle in which they are able to have independent facilitators come and assist with all types of things. And so I am here as one of the facilitators with the team who actually works in the office, and I'll primarily be moderating and facilitating this last part of your roundtable discussion. And so I'm gonna hand it to you. Did you want to say something?
Yeah, we're just gonna do a few poll questions. Okay, so it looks like we have about but I'm gonna wait a minute or two. Okay, I think, well,
What's the username? Mine says username.
Put your name in it.
Oh.
No, it's Rural Maryland Council
Okay.
573.
Gotcha.
well, it looks like we have about 50% is transportation. Little drops a little bit. Still moving along. Transportation is pulling out strong. But let's see, maybe we got a dark horse there. Okay, well, we'll just move. Oh, it looks like we have a 50% is transportation, 25%, 25% healthcare, others, and we do have policymakers as well. So that's good. Can we move to the next slide, which would next poll, which is which region do you represent? Yeah. Tanya just pointed out that we should have had another one all. So I would recommend that maybe for the work with most. How about would that work? Sorry about that. It looks like the eastern, well, here we are on the eastern shore. So that is pulling very strong.
We're on the eastern shore. I'll say the eastern shore.
That's a good way of doing it. Thanks.
Hey, Yolanda. I'll choose Western.
Yolanda, this is Mike Hill at Garrett Transit. I put both of my responses in and it's telling me that our presenter has not opened a poll yet. So it doesn't look like you're getting all the responses, at least mine's not.
Thank you for pointing that out. Okay.
It said that Juan Ardella has not opened a poll yet. So now there, I don't know if that's my response or not, but.
So you can try it again. They just reopened it.
See what this does.
Thank you, Leslie.
Nah, it said the same thing. So I don't know if you're getting mine or not. That's all right. I'll keep trying.
Well, sorry, I apologize to all the folks out there who are trying and are not getting an answer.
Maybe they're slow looking.
Okay, let's see, I guess we should. Okay, Jason, can we get to the next?
Is there a response?
Okay, now. Now. Yeah, but how do you get, now I'm having problems getting to it.
Yolanda, there's a couple comments in the chat too there that people are saying they're having trouble doing this.
Yeah,
So it's basically not letting you go do anything except you hit stop. No, it's not letting you go.
yeah, if to the people out, I'm having problems myself. So,
Yeah.
Texting is working very good.
yeah. Just-
Texting in Zoom, in the chat?
And-
You text on your phone. Use your phone.
Oh.
Text rural Maryland Council.
We're gonna start
Put
out.
the 22333. Yeah.
Yeah, I did too. First I put the other.
Yeah, this is John Hartline. I would like to say that this is the same kind of problem that I
I know, it's a lot.
did take me 2 tries to get it right.
Just in case the people who are hearing remotely, what it's been suggested is to text to Rural Maryland Council 573 and in text 22333.
Other way.
You're gonna,
22.
the phone number to text is 22333.
The phone number to text is
And the
22333.
message is Rural Maryland Council 573.
And the message is Rural Maryland Council 573, and Rural Maryland Council is spelled out.
And you can now put in the letter, so you should be able to, once you join, you enter the option that you want to select, and it should register your response.
I should really just pass this to Leslie, who's.
So once you select that option by texting Rural Maryland Council 573 to 22333, you will be able to enter your option, your multiple choice option. So one of the letters A, B, C, D, E, or F, and press send. And it's supposed to be able to register your response. Let's see if it's gonna work.
No, it's not. I've done that.
It just registered about 16% went to 24%. Now A has 9%. So it is working if that way. You just need to send it and it takes maybe a second or two to refresh. So we're seeing the numbers change.
Yeah, I did the text right away. It's not working on my end. I'm trying on the computer as well.
The text, and I was able to get to get it to bounce up. So thank you, Leslie. Thank you, Tanya, for suggesting that, and or whoever else had that idea.
The purposeful explanation of how transportation arrangement is for half of Maryland.
Yep.
All on purpose.
Yeah, I was wondering, we've got almost everybody has logged in. Do we want to go back and just restart a couple questions from the beginning?
Yeah, let's.
Can we jump back?
Jason is the one in charge of the polling. I tried and failed miserably, and the honors has now gone to Jason, our excellent AV person.
I can show them, but I can't. I can't.
Can you get a password for the Wi-Fi?
DCS or guest. So capital D, lowercase c, and then cat, lowercase s, and Sam, number 4, and then lowercase guest. G is in George, UEST.
Here, I'll bring it to you.
That's right, yeah, yes.
We have visual learners.
Sorry.
You're fine.
Oh, there it is. Should have been somewhere.
Yeah. Well, it was on that piece of paper, but.
So whichever question the poll is on, that's going to be what's registered. So it's going to be really important to tell people like this poll is ending. Go ahead and resubmit your response. You're able to Okay, so there, what's happening now is the questions, we're starting over because there was a request. Since everyone did not have access to it initially, we're going to resubmit poll responses. So the first question of what, I thought it was what region do you represent? So the first question is what region do you represent? So we want to go for this one? Okay. Got it. Okay, so this question is what industry do you represent? And again, it looks like people have already started responding because I saw the numbers fluctuating. So, yes.
If we were able to submit the first time around.
If we responded the first time around, do we need to respond again now?
No, you're already in there.
Okay. Yeah, you don't need to respond again because it device. One response per device.
We still have a lot of transportation.
Okay, it looks like, yeah, we're done with the, what industry do you represent? And I think the next question is the region question.
The next question.
For everyone who has not had a chance to poll on this question, please do so by using the text if not working otherwise. Okay. This looks good. I think we have it stabilized. Can we go to the next question?
And this is multiple, so. And this question is a multiple option question. So for those of you who are texting, like you would literally need to text one letter at a time. So if you have multiple sources of funding, text one letter at a time. If it's just one, you're just texting your one letter.
This one also looks like has stabilized. So
you were on this one.
For those of us that are texting, it'll only allow us one response. So you can't do multiples.
That's correct. Oh, so it's only letting you select one multiple choice option, and when you try to put a different multiple choice option, it won't allow you to?
Right, correct.
Okay, that's the setup. That's in the setup. So disregard, select all that apply.
Let's move on to the.
This is the survey result.
Yeah. Oh, wait. Okay, well, this is actually more of,
You want to go back to the PowerPoint?
Yeah, we want to go back to the PowerPoint. Okay. Here we go. All right. Okay, so here we're going to be talking about the survey. As I mentioned earlier, we put out a survey early July, early to mid-July. It was released. We had I think over 300 responses. So we had a robust response, which is good. And today we're going to go over some of the findings that we had. Here we go is the question, do you primarily serve a rural, suburban or rural population? You could see that the rural areas were the largest group, almost 2/3 of the amount. Suburban areas was significant, about 1/3, and the urban area was the smallest one, shown at 7%. Real quick, this is what region do you represent? I'd like to point out that this is the MDOT map, MDOT map. And although more people identified as representing rural interests, we do have a good mix of the 5 regions, which is important to remember that we do have that rural urban mix. And as you can see, there is a heavier emphasis on the more rural areas, with Eastern Shore was the strongest. followed by Southern Maryland, but rural components is also balanced out by a strong central region response, which is, is also good. And again, this is the MDOT map. Okay. Question is how, about the government. We had a strong government results. Government, particularly local government, was the largest group that responded to the survey. Nonprofits consisted of 44% of the surveyed group, and the private sector was only 9%. Okay. So here, how do you define non-emergency medical transportation? And as expected, basic medical appointments were the first items listed. Mental health appointments was a close second, and by almost a third of the representatives. And this may be a response to the pandemic, at least, could have been emphasized because of the pandemic response, but about 80 people wanted to recognize the importance of going to recreation centers and groceries. So that before pandemic, I don't think that would have been as strong of a number. This is what I'm trying to say. In your community, do you know what non-emergency medical transportations are currently available? Most interesting is that the biggest response was, I don't know. I mean, this is, and why that's most interesting is because this is the experts. These are the experts here. And if the experts are answering 50%, I don't know, that's telling me it's not very well defined. And that's something we need to work on. Many of these other services and many of the services that we do have for, that are listed here were actually set up for other services, like, for ride share or, free reduced bus fare. And that, which is actually becoming more popular. And what I mean is that there's nothing that's just specifically focused on non-emergency medical transportation. It's more like a component of a larger piece of pie, or a piece of pie of a larger pie. A piece of a larger pie. Okay. This one, I should have, it's hard to read this part here with the listings, but again, the do not know is still a strong component. And I'm going to point that out here because I did not get a chance to. It's the third column down. 35 people. It's still pretty strong, but it's not as strong as the knowledge of current services, which was the previous question. So in other words, what this is kind of telling me is that people know in their minds what's the most urgent non-emergency medical transportation, but they don't know how to get the services to those people. There's a disconnect, which again goes back to what we had just, what I just said earlier, is that, these are the experts and we don't know, there's still an emphasis, they don't know. What do you see as the greatest problem for addressing non-emergency medical transportation? The surveyors, identified that demand exceeds services. And this was, that description also included area, hours of service, et cetera. And this is true. I can tell you right now, studies have proven that 1 out of 5 medical appointments are missed because of transportation. The primary response recognizes that the demand exceeds the current services, and the funding was identified as well, and the lack of coordination. But what's also most notable is patient non-compliance was basically rejected pretty much as a problem for non-emergency medical transportation. The problem is not the patient. The problem is us. John, do you?
Oh, I think it's important to remember that the question here was the greatest problem. Doesn't mean the other things aren't a problem. It's not what people think is the number one problem.
Yeah. Very good point. I mean, actually, is there anybody else in the audience who may have a question or a comment about these, some of these findings?
Yolanda, I have a comment or just we can't hear you online unless you're speaking.
I just see that demand exceeds services may be because of funding. So those two may go hand in hand.
So this is Dwayne,
The microphone to those who don't have it. Do you want to answer? Okay.
Dwayne Yoder Garrett. The issue on demand could also include hours, for instance, appointment times and which always are somewhat of a problem.
This is true. Okay. In your community, do you know who is eligible for non-emergency medical transportation? Medicaid recipients are, of course, identified with non-medical transportation. Also, we recognize paratransit and ADA compliance as, if you go within 3/4 miles of that delineation, all of these groups have varying levels of support, and the level is not necessarily based on the needs. Like, for example, homelessness is, identified here, but it's kind of falls very low on the scale. But this, those are the folks who probably have a hard time getting to their appointments. Okay, now who do you think should be primarily responsible for managing and coordinating non-emergency medical transportation? By far, public-private partnerships was clearly favored. And it should be remembered that the majority of the respondents were government folks, and nonprofits were 43%. The government was 47% and nonprofits was 43%. So that combination seems to be a good win-win. Local agencies were also, local agency was also preferred over, a state program too, which I thought was kind of interesting. And healthcare and hospitals, ranked, below that to be primarily responsible, which was interesting. Does anyone have any comments or?
I'm Alex Handy with Maryland Upper Shore Transit. I met with our hospital, local hospital here, and I suggested that they promote, if you need a ride, call DCT or Queen Anne's County Ride, and put that in their advertising. When they confirm an appointment, they might put on there, if you need a ride, call this number. Because we do have transportation here to medical appointments if you give us enough time. But that seems like a logical thing. I really didn't get very far with it.
Okay, any other comments? Okay, now Jason, if you could do the next poll question is.
Yolanda, you want me to take it from here?
Yes, please.
I have my right here. All right, so this is our next poll. After reviewing all of the survey results we want you now to either text or select through pollev.com your option for why do you think there's such a high number of expert responders who do not know current non-emergency medical transportation options despite the need. And so I'm gonna let folks continue to respond. And so far, few people say it's not my area of expertise or that it's not easy to find, but overwhelmingly, it's clear that one of the primary problems is that no one understands what their role is. Clearly defined roles, there's a lack of that here. And so that's what is coming up with our survey results. So I'm gonna keep it up for a couple more seconds and then we will close it out. Okay, and you all have been talking about that. I was on Zoom earlier and now here, you've been talking about this often. Did anyone want to make commentary on this question, this result? You can, Yolanda. Did you want to say something?
No.
Okay.
Actually, I think John made the comment earlier about braiding funding. I think we also braid organizations here. You've got the nonprofit, public, transportation, public health. And so, and because this is such a big part of life, no matter what you're doing, whether it's health or education, grocery store or dialysis, we do need to set some parameters potentially around who does what best and how does it all braid together. Mapping of that.
Thank you. Awesome comment. I think that is something that should come out, hopefully, with the work that this group is doing. Hopefully that will be one of the outcomes. So now we can,
Yeah, I just wanted to say for the we're experts, but I think sometimes we all think the other person's doing it. So a lot of people think that it's Medicaid, that like we talked about. When we testify for the be responsible for doing this. And so there's just, I think, a belief that somebody's doing it, but we don't know who that person is. And it's that other person.
Right. And that, again, no single group, we don't know who's doing what. Maybe there's duplication of efforts. Maybe there's nothing happening because I thought Medicaid was handling it. I thought hospitals were handling it. And so any other comments or things folks want us to keep in mind for this poll question?
I would, part I think the challenge is that in other states, the managed care organizations actually can control some of the funding or get delegated to manage the transportation. So you at least have that entity that can help coordinate the services. But in Maryland, it's very different. It's dependent on county. And so that creates a challenge as well.
Thank you. And if you could just announce your name and what organization you're from.
Yeah, Lorena De Leon, and I'm with Maryland Physicians Care, third largest MCO for the state of Maryland.
Okay, thank you, Dr. De Leon. We can't see your picture, I'm sorry. We can't see your face in the room, so I wasn't aware of who was speaking. Okay, thank you.
I'd like to follow on that. And I do know that at least from Southern Maryland, and I think it's true on somewhat on the Eastern Shore, the healthcare system that we have in Southern Maryland is designed to have a local component, but for specialists, you have to go to Washington or Baltimore. And so we're pretty good at the county level at carrying people around Charles County or St. Mary's County or Calvert County. But if you have to go for a specialist and it's in Prince George's County or Washington, D.C., or you go to Johns Hopkins, there isn't really anybody who's doing large, long distance travel or support for people who need specialized care.
That's an excellent point. We've actually faced that several times as a managed care organization on a daily basis. We recently had one of our community members who literally had surgery in Prince George's County and needed to go to Baltimore County for a follow-up and could not find transportation. And it took 3 weeks to be able to coordinate, and we ended up paying for it out of pocket for transportation post-surgical follow-up, which was ridiculous.
So not just, the awareness or knowledge of who and where can I get this transportation from, but also the capacity of the area and jurisdiction. So if you don't have the services available in your county and having to travel to another county to get services, that becomes a challenge as well. And so we're going to go ahead and move to the next poll question. And this poll question is, what would be the greatest improvement that a public transit system could make to provide better non-emergency medical transportation? So again, let's take a couple of moments to provide our response. The options are A, expand hours and structure of service. B, E, on-demand versus appointment, or F, expand healthcare destinations? Great, I saw some response. And again, I don't know if folks are joining late or not, but if you are not able to select your option directly from the website, you can text Rural Maryland Council 573 to the number 22333, and then type your letter in your text message before you send it. All right, so we are getting responses, and looks like folks think that if we improve the hours and structure of services and on-demand versus appointment processes, that could, provide better non-emergency transportation. No one selected increased frequency of trips. Why do you think that is? Anyone want to comment?
I'm glad you asked that question, because I was thinking that myself. And I think that this group recognizes the fact that for non-emergency medical transportation, it's not a matter of the number of trips, but it's the matter of targeted trips, that we want them to be targeted to pick up the people that we need, the chronically ill people who need to get to their appointments and get them to the places that they need. And it doesn't mean we need to expand, hours. Doctors are open only a certain number of hours a day. Then it becomes not, in the evening, maybe, what are you going to do? Go to the emergency room? Then that's something else.
Thank you. And so increasing the number of trips might not be as relevant as really making sure that when people need the trips and the people who need the trips have the accessibility.
And could someone speak to definition of on-demand versus appointment and what other types of structures are out there in the world?
Yes, one moment. And what's your name, ma'am?
I'm Suzanne from Cecil.
Suzanne from Cecil County.
So I can speak to this just because we have successfully piloted an on-demand system. So my demand response is not ADA paratransit. I do deviated fixed route instead. So that means I can say no to trips. So if I'm at capacity, if I have 3 drivers on the road, which is all I have right now due to driver shortages, and you call me at 1:30 today for a ride tomorrow, I'm probably telling you, I'm sorry, I can't do that trip. Where on demand is, if you've ever used Uber or Lyft, is exactly that, but it could be operated by a public transportation provider. I did a on-demand pilot through an IMI discretionary federal grant that provided transportation for individuals that were in active recovery. It was a very successful model, and we have continued it since, but it does expand. It checks all the boxes, and it's very dynamic, and you can create zones for where these trips can occur. So maybe you're not duplicating service. If you have a really robust fixed route, you wouldn't necessarily need to run that service in the same area, but you could connect to the fixed route, which could maybe get people to and from. So you could use it for like first and last mile and that sort of thing as well.
Thank you. Got another comment in the room, and then we'll check in with the folks online.
Chris from Carroll County. Another model to look at might be something we've already done in Maryland, which is our public school system. So the subsystem, for example, has changed over the years to be more on demand and open. So I've subbed for Maryland schools for many years, and so I know this from experience. It used to be you got phone calls at like 5:30 a.m. in the morning, and you could like basically select or not select, and you kind of had to answer or silence your phone. They switched to a model now where basically any area you're eligible to sub in, you can log into a website, and I can pick out a month. A month of work. If I know at least 2 or 3 that I've worked in have adopted, but it's a model that might be worth looking at. taking from our public school systems into our healthcare systems.
Thank you. Does anyone online want to comment or have a question?
I'm glad to comment. Again, this is Lorena. We are actually working on a blueprint around this with a multimodal company that can actually use the platform for the MTA, as well as bring in Uber and Lyft, and additionally the non-emergency transport, so that now you have a variety of options for the community to tap into, and you can bring in nonprofits. It's all a centralized platform. And ultimately, that's probably what will help solve a lot of this problem, is having one centralized platform that can do multimodal transportation and can handle different from like ambulatory to full ambo transport needed. Because again, coming from a managed care organization and from the hospital system, this is very difficult to manage. You never know what your patient's going to need. And so having that option really increases the chances of them getting what they need.
Thank you. Yolanda, were you going to say something, or did you have anything to add here?
Yeah, I'd like to add just on-demand versus appointment. You know, our program is kind of an on-demand program, but I do want to add that, and that's the Wheels to Wellness program that was mentioned earlier. But the one thing I would point out is that in the rural areas, getting companies like Lyft and Uber is very, very difficult. They're just not there.
You're right. And I will say that we're actually working with Lyft and Uber, and I know my colleagues on the phone from the Department of Social Services, we're gathering data. And what we've actually done is we're bringing together the Chamber of Commerce, UPMC, and basically getting all the data together and make a business case for them to actually come out and build a network. It turned into us as Maryland Physicians Care saying we can't guarantee more than, these many rides a day to a potentially $10 million opportunity for them. And that made them come to the table to listen.
And that's exactly why Cecil did our project, because there were no Uber or Lyft options whatsoever. So we just basically ran an Uber or Lyft type service.
That might be a good strategy to expand Uber service into the rural areas. If we can hook them in with guaranteed non-emergency medical transportation, then they might be able to pick up somebody else for their haircut.
Yes.
Glad to bring the people to the table from Uber and Lyft, since we've got the contacts and we're already working with them.
Right. Some of the challenges that we have sharing with Partners in Care, working with an older population, they don't feel comfortable using Uber or Lyft. They don't necessarily have the technology to be able to recognize, is this the person I'm supposed to be going with? I had a lady up in Edgewater. She had a doctor's appointment. Her son had set up an Uber account. And he says, Mom, Uber's going to come. And she says, I'm not taking Uber. And he said, well, why not? She says, well, I don't want to be raped by the driver. And so I asked her, I said, well, would you take a taxi? She said, oh yeah, I'll take a taxi, because that's generational. She grew up with taxis and she knows taxis, but Uber and Lyft, and also too, the other challenge, and no one answer is a panacea, but Uber and Lyft don't necessarily have accessible wheelchair accessibility. So that eliminates a significant portion of the population. So you kind of need a lot of hands in the pot to make it work.
Just to let you know, Lyft is actually working on something called Lyft Assist, which is a whole new slew of cars that will be able to do that. So again, just an option, right? And if taxi, this would all be solved with a multimodal platform that can handle multiple venues.
Before we, okay. Yeah, so sorry, I'm not sure who was speaking, but your reception was going in and out. And so we're gonna ask for one more comment just in case someone has it, and then we need to go to the next poll question. And so if you haven't shared already, this would be an opportunity to share a comment or ask a question to the group. Anyone? Okay, we can go to the next question. All right, so now that there's some really good discussions going on here, leaving us with some things to think about. So what do you think should be the first priority for defining really good non-emergency medical transportation? Should we be identifying or addressing medical destinations? So where are people needing to go? Should we be identify or address geographic challenges first, such as we talked about, in the rural areas, can't even get a Lyft or Uber? Or should C, identify or address medical population first? So really go in and assess what are the, medical demographics here? Is this an area record your response or submit your response so that Poll Everywhere can record it? And this is a thoughtful one because really need to think, and it is going to be different depending on where you're at, right? We're looking at the whole state of Maryland, where challenges are definitely tied into different factors. I heard someone say earlier that it would be nice to really have something that wasn't based on region or jurisdiction, but more so one standard definition so that everyone can understand what is non-emergency medical transportation and really, again, going into those role definitions. But drawing our attention back to the poll, seems like still got a couple of more responses coming in, but overwhelmingly folks think that we should be identifying and addressing the geographic challenges first. So really looking at the state of Maryland and seeing, where do we have the most challenges? And as we saw earlier, Southern Maryland, Eastern Shore were the areas that were anyone want to comment? Or if you're confused by that number, did you want to ask a question in the room or online?
I'd love for you to go through the three and explain exactly what those mean.
Okay, so I'm gonna let Yolanda, because I don't want to, I kind of gave my little definition, but she can give her elaborate definition.
What do you think it should be the first priority? Do you think it should be, we need to figure out the hospitals and dialysis centers and make sure that people have transportation there? Do we want to address, just the medicals and hospitals out of region, in region? Or do we want to turn around and address the fact that there's rural areas and urban areas that are deserts, that just people don't have any options at all? That would be more geographic. And the third one is population. Do we want to say more money for dialysis patients, more money for cancer patients who need to go for chemotherapy? Or, and that would be the 3 options. So number one, the destinations. If you're in rural, in Southern Maryland, you need to get to Walter Reed, that, and you see that as the first priority, then you hit A. If you think that, well, I'm down in Nanjemoy, Charles County, and I need to get to the doctor, then you pick B. And if you want to say, I see the problem is dialysis, people who have dialysis, but they can't get to the clinics, pick C. Is that the answer?
But even though dialysis was chosen, even though dialysis was the example she gave, it could be that in general, like, do we need to address people with chronic conditions or existing conditions right now before we think about those who are just having preventive care? That's what you're doing there. And that would require an assessment of the area, of course, and to really define and identify what the level of need is, the different types of needs. So it looks like, were you already able to enter your response?
No,
or?
I'm going to hold out on this.
Okay, got it. All right, any other?
We have a high number of people from the Eastern Shore, and which does have geographic challenges. And Southern Maryland, which also has geographic.
Even Western Maryland has major challenges over there.
The rural areas.
Would you interpret that means that a one-size-fits-all approach is not necessarily the answer?
And the question was, would you interpret that as a one-size-fits-all approach is not the answer?
The one-size-fits-all is probably not the answer.
Any other questions or comments from the room or online?
I just want to say we're from Western Maryland, and I think that we definitely need something here.
I'm sorry, you were going out there. Could you repeat that, please?
It's Darlene Valentine. I'm from Hagerstown, Maryland, and I think Western Maryland desperately needs help with transportation for people.
Thank you. Anyone else from online? Okay. So with that, we will go ahead and move to the next question, which is, who do you think would be better to request the non-emergency medical transportation ride? And again, you have A, the patient always makes the request or should make the request. Always the medical care provider should make the request is B, or C. Either or, anyone can make the request, doesn't matter. So again, A is just for the patient should make the request. B is for the medical care provider should make the request. And C is for either patient or medical care provider should be able to make the request. Okay, it looks like people are pretty clear with these three options on who should make the request. And since it's over 50%, I'll just say now, it's coming down to C, where the majority of people feel like either the patient or medical care provider should be able to make the request, or would be ideal to make a request. See 11% with always. It's not best to let the patient make the request, right? Especially if they don't like physicians and nurses, they hate hospitals. I've, definitely dealt with people who we had to force them to go. And that's including the transportation services that we coordinated them, refusing them and sending them away. So, and then us having to get more transportation. So sometimes by allowing the patient to be the only one, that patient or that person might not get adequate care just because of their feelings towards physicians and hospitals, et cetera. So anyone else want to comment or ask a question about the statistics that we have come to here?
Thank you. So it's kind of a loaded answer there, the way you have it always the patient or always the provider. And I'm thinking of like here in Dorchester County, Delmarva Community Services, I can see a lot of situations where maybe the medical provider will make the appointment and the patient forgets about it, or they just don't, and they send their resources out to the patient's house. The patient's not home, they're not ready. That's quite, something on them as the provider. So saying always, or, versus this, whenever you put that always in there, it's always scary. But I'd like to, it looks like we're question 7 of 7 here, but Keith, Delmarva Community Services, are any of these answers surprising to you? Is this something you and Sandy, have in the back of your mind that we know these are some of the main issues?
Well, you want the responsible party to be the one doing it. So whether it's the mother, stepmother, father, individual, you want that person to be the responsible party, because you may not have any kind of negative thing you could give to these people. Well, it's easier to find a pattern if it's one person being responsible to make that request, and that's the problem. If we don't have the same caregiver, the same, if it's not, usually there's a pattern, and you can pick that up, I think. I mean, you guys can comment if you want, but.
Keith, going back, because you were in here for all the survey questions, looking at all the survey questions, was anything a big surprise to you?
No surprises. It comes down to, and to your point, that, for an example, we'll receive scheduling from the health department, and then we'll go and we'll send the bus to pick the person up, and that person will say, well, I told them I can't make the appointment today. And we don't get that information.
Right.
So we have the expense of the bus, the driver, and things of that sort. So, and it also gives us some redundancy if we have that from the caregiver or the patient, that we can log that into our software system. And so we can trend those no-shows and those cancels that I was talking about earlier on who's responsible for who's mismanaging the appointments. So it doesn't come back always that transit failed to get someone 1 out of 5 to their appointment. We have documentation now.
Does your system account for maybe a dispatcher to call the next person in line for a pickup, say, hey, Miss Martha, are you ready for us to come get you? Or
no, sir.
Okay.
No. As I said, medical appointments through MAT were over 2,000 a month. We're over 300 trips, self-pay medical appointments. So it would be very demanding of our dispatchers to have that. And then we have in our software program, we have all their information, and people change their phone numbers, and it's just people move. We went today for an example, to 200 Washington Street to pick someone up to go to Salisbury, and to come to find out now they're living on Ray Street. Those things happen day in and day out, and it makes it a struggle for transit.
This is Darlene from Family Health Care.
Early on, and it still is one of our chief objectives, was we studied what was done by Mike Pennington and Shore Transit over here. And they had what I felt was an extraordinarily high no-show rate. And your no-show rate is, still pretty substantial. And that's why we had the actual care coordinators and the patients agree on the appointments and when they should be made, and why we would often have the care coordinator call the day before. And because of that, our no-show rate was running between 2 and 4% among the patients that we had. But it was mainly because it was being focused on by the patient and the care coordinator and the doctor all agreeing that that person was going to be at the appointment. And when they wouldn't come out or they didn't come out, we actually had the driver go knock on the door and try to encourage the person to come out. And the same driver routinely would handle the same person. So the person was elderly, or if they had challenges and we had to wheel a wheelchair down a stone driveway about 50 yards to get it to the van to get them to the doctor, it was the driver that was our key to making sure that that happened. So I don't know if that's doable statewide, but that was doable in the project that we were, the pilot project that we were doing.
So this would even be a different option, like option D, which is both the patient and medical care provider, maybe medical care provider team, depending on who it is.
So I think it's important. And when, you talk about the problems we currently face, and then you look at potentially having a larger solution for the state of Maryland, I take the approach of we're going to have an iterative process anyways. So let's start being as inclusive as possible with as little block experience and data. We can start to iterate on how we need to, change, or, what do we need to, hire specialty drivers, for example, that, take the harder cases in terms of that need the more care. The other thing to think about is if we do approach this from a larger state of Maryland approach for transportation, that also could free up time for our local caregivers and local care organizations to spend more time doing things that isn't transportation. So that's another important piece to think about when you're, approaching this.
I think the one thing I keep hearing is the team effort that they're, I'm sorry, I'm Tanya Nichols with the MDOT/MTA Olds office. So the one thing I keep hearing is the need for a joint effort. Caseworkers working with transportation, communicating with the patient, back to the caseworker to make sure that the patient communicates with them, that transportation knows not to pick them up or they have been confirmed to pick up. And that's the one thing I keep hearing is the joint effort from both the healthcare environment and the transportation provider on a consistent basis. And do we have the capacity when we think about funding? Is there a capacity to actually achieve that ultimately long-term?
So 1 second, just wanted to make sure we leave space for those online. Did anyone on, because that's 2 in a row, we got to have some little bit of order. Anyone online want to comment or ask a question before we go to another question in the room or comment in the room?
Yeah, this is Darlene Valentine from Family Healthcare. I just want to say, being that we have our own transportation here for our patients, I think that you're always going to have people that no show. My driver actually prints his schedule in the morning, calls every patient, tells them approximately when he's going to be there to pick them up. And some people just don't come out of their house, or like the gentleman said, they moved and we don't know about that. So I think that's a problem, but we're always going to have that issue.
Okay, so like the reception went out, but ultimately, sounds like that was resonating with what she heard in the room. And go ahead, ma'am.
So with Partners in Care, we asked the individual to give us 7 days notice to schedule an appointment. And we work to find a driver. Once we find a driver, then we call them to say, hi, Miss Jones, we found a driver. His name is John. We only give first name. And he will call you the day before to introduce himself and tell you what time or ask you what time you want to be picked up. And typically we have a low rate of no-shows. Our members, part of inclusion in the Partners in Care program is you have to be able to advocate for yourself. In some cases, it may be a mom who's advocating for her daughter or vice versa. But you need that, the collaborative approach is huge, but unfortunately, in larger areas, there's no way possible that a dispatcher could call the number of people. When I worked, I was the mobility director for MTA many moons ago. And on a busy day, we might have 3,000 trips. So there was no way somebody was going to be calling saying, hey, are you going today? Or we'll be out there to pick you up at such and such a time. And then part of it too is the population that we're dealing with. If you've ever driven a bus and you've secured a person in a wheelchair, depending on who the person is, how long it's going to take them to get out there. So do you go to the door and you, as the driver, push them to the bus because it's going to be quicker? It's a domino effect. And so it's kind of like, how do you eat an elephant? One bite at a time. And so it's a collaborative approach. One method is not going to work. And you in one area, it might work here. You use something else a little bit here. But if you call together all the pieces, then you'll find that it does work. But just one simple thing just won't do it. So.
And that goes right back to there's not one size fits all, but maybe a myriad of tools in the toolkit and use the one that makes the most sense or will have the most impact. We have another question in the room, then we'll go ahead and go back to online.
Sarah Seitz, Maryland State Office of Rural Health. This also makes me think of if you are making appointments in the medical care office, there are lots of process improvement steps that go along. And sometimes I remember sitting in a federally qualified health center and having to have the conversation of, we need to have expectation setting conversations with patients. We wouldn't expect that we'd have to let somebody know, but if you haven't been told in life, This ride is coming to you. Someone is paying for
Yep.
it, even if you are not, and adding that value and having the conversation. So I think that does become difficult over a whole statewide program, but then it does become someone's job to do that. And that might be part of the conversation as well. When you have thousands of riders, where do you set expectations, hopefully to impact some of those no-show and cancellation rates and build value to something that's free to them potentially.
Anyone online? I know we had a technical issue where someone dropped off, but if you wanted to continue what you were saying, or if someone else online wanted to comment or ask a question, and then give you a couple minutes to unmute yourself and do that. Or a couple of seconds, I should say. Okay, we have another comment in the room.
So perhaps a level of coordination puts scheduling as a gatekeeper with people who have skin in the game, a budget, if you will, and their services. It becomes incumbent on them to work with the local resources to identify the populations that we're going to serve and the parameters that we're going to do that. And everyone is allocated a certain set of resources. And if you squander them on failing to educate your individuals and you provide people who are reliable and can utilize the service effectively, we then don't waste resources. And that isn't transit. We should be, I'm sorry. I'm thinking that as transit, we should be able to rely, we'll do our thing and we'll do our thing the right way, and we'll care, and we'll do a great job. And we'll be able to tell you when we can't. That way you can manage, the gatekeeper can manage expectations at all the way down to the patient level, but probably the organizational level. And that's where I think the state of Maryland provides the overarching controls and sets up that coordination infrastructure in the local areas and charges that with working with the providers and the users of the service to develop what it looks like locally. And we don't lose the piece, little Eastern Shore punch. We don't lose the piece that gets us, that gets my people over the bridge to the care that they need and they cannot get here. So thanks for indulging me.
No problem. Thank you for the Eastern Shore plug, because I am from the Eastern Shore and I have reliable transportation. I don't have that issue at this time, and maybe I'll need it in the future, but this is something that's near and dear to my heart because the community members, they need to get over the bridge. Sometimes because they can't get over the bridge, their now appointments are a month or two out. Yolanda?
First, I wanted to say this question, in answer to the question about using the word always, it was written to be provocative. It was written to make a conversation. And I just wanted to point out when, I don't know about you all, but when I go to the dentist and I'm or with my face half, they make sure that I'm there. If they left it to me, it might be
6 years.
You got it. That's it. So that's, and it is, it should be a cooperative and almost like a case by case basis, but there needs to be some kind of level, where something that's done at some kind of hierarchy or something. I'm not sure what the answers are. That's why we're here. But, I just wanted to offer that. Think about the dentist.
Okay. So we're going to have one last comment in the room. Before we do turn to him, though, I just want to make sure that there's no one online that wants to say something or ask a question. Okay, so you want to just grab that mic and then we'll, you can just turn it to you. You don't even take it off the stand.
Yep, Scott Warner with the Mitchell Regional Council. I was waiting for the last question because you started losing me on question 5. And that was, I don't know if I've just been around transit too long and, we're not a transit provider. But as soon as I read that one, it was like all of a sudden the onus turned to putting all the onus on the transit providers. What can the transit system do better? I waited till I was going to ask it then, but I wanted to wait till the last thing thinking I didn't want to jump ahead too far. I didn't see anything about what is the healthcare system going to do. And we've tried some stuff 10 years ago, back with DCT, to be quite honest, in our local hospital system. And the hospital system didn't move. Actually, we got very close, and the one champion, the one vice president ended up moving, and nobody else picked up the ball. We had universities involved. We had public transit involved. We had a certain sector we were going to at least try to do to coordinate scheduling. In the cancer center is where the hospital chose. We've often heard that the medical system, and we knew why they came to the table. They came to the table because they were losing like 30% of their patients couldn't get there. And that's the only reason they came. It was money driven. And yet we turned on question 5 was, what can the transportation providers do better? And I go back to your comment earlier. You said you need like $300,000 in this one budget, and you only have 100 and some thousand. That was just on the share rides. It's all money. We can do a lot of stuff, but I don't know if everybody has to come to the table. I don't think it's going to be just turned to the public transit providers with paying a bus driver, minimum wage and going, great, we're going to do it. I mean, I've heard stuff like school bus. School bus is easy. You put a bunch of kids on one corner and you pick them up. That's not what they're dealing with. They're running dialysis patients from, Fredericksburg or Hurlock. And so I don't know if it's easy, and I know it's taking it one bite at a time, but 7 days to book something, they get a call in the morning to get a dialysis the next day. That's a whole different animal. And so I don't know. I'm just kind of following this, and I don't think it's all on the public transit providers. I'm sorry. I don't want to know what the health system and, is it just everybody getting on to get more public money into public transit? And that's everybody under the same tent might be a big thing. So anyway, thank you. I just was just waiting to hear.
Wanted to comment. So definitely want to make sure that we get a couple more comments in. This is our last question before we talk about next steps. And so I see at least 2 people, maybe 3. Okay, so at least 2 people at the table want to say something, maybe some folks online, especially from what was just pointed out by Scott, which, what can the healthcare system do better? And so I want to go ahead and let those comments, because I think it's very valuable to this discussion, and then we can talk about next steps. So 2 people in the room, and then we'll save some space for folks online.
So one of the words I wasn't sure if I was going to use today, but has been, it's not 4 letters, don't worry. But has been given to me many times by our transit members is dumping. And I know it's one of those harsh words because we know these are people. They're not cargo, they're not trash, but we say that they are dumping these people on us is one of the ways that a lot of transit agencies feel about this, that there's very little concern in too many cases. And I'm so glad to hear about cases like Wheels to Wellness where there's genuine coordination. COVID crisis, what do? Send them to the transit system. Medicaid finds a reason not to consider someone eligible for medical assistance, send them to the transit system. So I've said more money because obviously, what else am I going to say? But I'm really grateful that someone else brought it up first so I could glom onto it, that it really, if we just come out of this with a saying, hey, let's make sure the public transit does a better job, will do a better job if it gets better resourced. But it's going to have the same inefficiencies and the same lost opportunities. And you're just going to have this discussion again in a few years as the population continues to age into an area where it grows beyond the resources that we're capable of providing. So I'd like to say that when you go to someone and tell them that it's a crisis, they come back when it's a catastrophe. There are agencies that are starting to feel, and COVID really upended a lot of this, and in some ways it delayed it, but it's coming on again. There are agencies that are starting to look at this in the near future as a catastrophic level event where they're starting to think, well, what are the ways I can manage to keep my head above water? Is it going to be by cutting service routes so that I'm no longer required to pick people up, just so that I'm able to meet the legal requirements that are on me? And we really, really don't want to see what that's going to end up looking like. So it's a partnership, and it's got to be both sides at every level coming to the table. And I think some people have to be very politely and heavily encouraged to come to the table and agree to work together in a real spirit of camaraderie.
Thank you. All right, John.
Well, I'm going to come to the defense of the transit people myself. We allocate funds, a specific amount of, you can call it dollars, it's actually miles, to the care coordinators at the hospital. And we say, okay, you have 957 miles. When that's up, that's it. And if you spend more miles this month, we're just going to subtract them off your quota for next month. So we don't, at the transit portion, or it's actually the people carrying ours is the ARC of Southern Maryland. They're doing the transit, but the care coordinators have to make the decision who rides and who doesn't. And I'm glad that I'm not the one making that godlike decision, number one. They have a limited resource. They have 970 miles. When that's gone, it's gone. And the state just has the ability to put more miles in the bucket, but the state can't put an infinite number of miles in the bucket, and we can't either. And the reason when it's gone, it's gone. We wrote that MOU because I learned a lesson from Scott that the resources are not infinite. And we wrote our MOU, when the money's gone, there's no more rides, because that's the way it has to work. Both sides have to understand that transit is a limited resource. It's not infinite. We can't keep filling the bucket up.
Thank you, John. All right, Yolanda, I just want to check if anyone online, and I'm just going to turn it back over to you. This is our last slide. It's for the polling questions. And so anyone else online want to comment before Yolanda goes into last comments for the polling and wrapping up?
Yeah, this is Earlene Valentine again. I want to make the comment that we work in medical, and to answer to the comment of what is medical going to do, what medical should do is have outreach workers work with the patient, work with transit, and work as a team to get whatever you want accomplished. Like I said, we have our transportation here, and we're just small. We have one van, but we have outreach workers that work with the patients and, you know, tell them how important it is to get here for their health care. We have our driver who calls the patients in the morning to confirm their appointments and, you know, make sure that they're ready when he's there and takes them home. So it's a group effort. It's not just on one person or one group of people.
This is Lorena DeLeon again, and I would love to agree with what Darlene said. You know, I think the transit system does the best job that they possibly can, and we commend you. And I don't think that anybody should feel that they're being dumped on. But again, this is about coordination. You know, we've talked about hospitals and we've talked about healthcare, but again, I represent the payer side. And ultimately, this starts with the funding and the distribution of funding. So it really needs to be looked at from the top down to really create a better system where we can all coordinate together and ensure that the person in the middle, which is the most important, the patient, gets what they need.
This is Nancy Huggins with M.MTA, the 5310 grant application for the nonprofits. The highest scoring number that you can get is for coordination. So for any nonprofits that are going after this particular grant, that is one of the most important pieces to your puzzle. So you coordinate with the transit agency, you coordinate with the state government, you coordinate with the health department, you coordinate with everybody, other nonprofits, so that there is no duplication of services and that there is no dumping on the transit agencies, because everybody plays a key role in this program. I'll get off my soapbox.
You're right, though. You're right.
Yeah, I think we had one other, Elizabeth Beck wanted to make some comments. She had her hand raised. Ms. Beck? Yeah, I'll be sure to unmute. Thanks, Leslie. I think you're still muted.
Can you ask her if by clicking that, we got started. It should give a box that will pop up.
Yeah,
He just asked her to unmute. Find the option. She's still muted, so I would say until she unmutes, you can go ahead.
Okay, actually, I wanted to say a comment too, because this is very good conversation, and it's not, I don't, I don't think that the healthcare industry means to, quote, dump, and I don't, and it's unfortunate to hear that term, but at the same time, it's unfortunate to hear that term. I think what the problem is, it's more of we're mixing the non-emergency medical transportation with regular transportation. And it's almost like we need to unmix it and figure out a way to, target that group.
And I did want to say, I think I said this before, but like, I'm not an expert in transportation. And so I've been asked, why don't you just start your own van? And I work for a hospital. I shouldn't be starting my own transportation. So that's why to me, the partnership's so important, because a lot of people don't need help, and so this is like a small portion of the population. However, they really, really need a lot of help. So I would rather partner with somebody else so that I can do what I do best and let them do what they do best.
It's starting to be really expensive too.
Yeah, and we would have to get a driver and we would have to train them. We're not doing that. So it's in our best interest from the healthcare system to partner, is my opinion.
So, and it makes sense from, it's not your expertise. Do you think the healthcare system would be part of the funding of finding the experts to do that?
I mean, I know that people think that hospital systems have a lot of money out there, but we don't. So there is total cost of care. We're going to lose money if we have a high readmission rate. So in that sense, it's in our budget. So the case managers are not paid for by, they're part of my hospital budget. So when we do the care coordination, the hospital covers that. That's the medical side. But the actual transporting people part, I'm not sure that that's really always appropriate within the scope of healthcare. So.
I just like it.
So this is Suzanne from Cecil County. I just like to say that, I hear that, and it's not just healthcare that really is asking transit to do a lot of things. It's the employment industry. It's a multitude of organizations that have big asks. And the truth is that until the day that we can take everybody door to door, whenever they want to go, going to hear transportation's a barrier, transportation's a problem. But I think that if everyone who needs transportation would contribute a little, it would help us be able to do our job so much better.
If I could, Lenny Pfeffer, Dorchester County. Something else, it's not going to fix a large percentage of these issues, but I mean, maybe we have to look also into some mobile integrated health. Some of the counties are trying this where you actually have a coordination between the hospital and the EMS system. So you can have a PA or a registered nurse and an EMT that can go out to some of these the homes. And, you know, if you have a PA, they can actually write prescriptions and they can do some of this work. I know that telehealth, it has some options, but in the rural areas, the access for internet and stuff is not as good. But some of the mobile health units can have some better equipment also to possibly create a better communication between the person's doctor and the patient. So that kind of helps on a small percentage. It doesn't help with your dialysis, your major specialties, but for some of your routine issues, maybe doing house calls, you know, like they used to do, may help for a small percentage of some of these patients. I've been in EMT for 30 some years, and you'd be surprised how many people they'd call for an ambulance and you show up and they have their suitcase in their hand. So it would help, especially with some of your frequent flyers, you know, and some of your patients, to help give general basic healthcare at home.
Yeah, telehealth is, and telemedicine is growing each and every year, and especially with COVID, we really push that. And you brought up a point about rural broadband is a big issue as well. One of the things I'd point out is the impact that the Affordable Care Act had on with the question about the transportation, because there is you know, there's penalties and that are given to the hospitals if they have a high readmission rate. So there is a vested interest by the hospitals to participate in this conversation. That's the other thing. And the other point is that it's really, as Noelle mentioned, it's really not a very large population. It's very small. And correct me if I'm wrong, but it's like 70–80% of the hospital resources, costs are usually tied in with a very small, maybe 5% of, no more than 5% of the population of their patients, because it's just that small group requires so much help. So if it's just trying to figure out who that group is and making sure that they, can get their appointments.
And some of that can be addressed. A couple of years ago, up in Frederick, they had that issue where you had 108 patients who had used almost 1 million. And so when that person had their suitcase, they're going to be in the hospital. They're going to have a nurse attend to their needs. They're going to have someone to talk to, and they had one case where a woman, she kept coming periodically the same amount of time. And it turned out that her husband had passed and she was by herself. And so, of course, when she came into the medical system, you had a bunch of caring individuals. So she liked it. And so she continued to do it until they tried to. So it's when I talk about a real sort of collaborative approach, you look at people who are so lonely. You talk about, and how does that translate to other issues? Scams. Sometimes the scammer is the only person they've talked to in a while. So they're willing to buy a little something just to have that conversation, which is a sad reality. But I go back to, we have to look at a number of factors that play into it, because a lot of times those folks who come and get that ambulance don't really need that ambulance. And so trying to figure out how can we better serve and mitigate some of that and put it in places where it's truly needed. And with respect to transportation, I've always said, Nancy and I had a boss who said, transportation is God's work. But I always emphasize that the driver's, his job is to drive the bus. And so sometimes, especially with older populations, we ask a little bit more of the driver than we should probably ask of them. And so, I always remind people, the driver is the driver. It's his or her responsibility to safely get you from point A to point B. And, we ask them, well, look at this, or be on the lookout for that, or da-da-da-da-da. his job is to drive the bus. Now, he can be courteous and he can be friendly, but we have to remember what his job is or her job is. So.
And I think one thing, sir, you had said before about sympathy. We have to be sympathetic to some of the patients. It's hard for some of these transportation companies at $13, $14, maybe $15 an hour to hire a CDL driver, and we can't force them to be sympathetic and the caring. It's hard just to fill a driver's seat sometimes, much less fill a quality seat. You know, have a quality employee. So I really feel for all of the transportation companies trying to get that quality, sympathetic employee.
Sorry. It just occurred to me financially, I'm just thinking about from the health system perspective, something that most people don't know is that if patients, and this is not even non-emergent, this is patients don't pay their ambulance bill, that comes out of my budget. So it might be that my hospital can't give money to a community group to provide transport, but for me, I think it's like maybe 30 or 40,000 a year, which I know at a small hospital that we pay for delinquent accounts. And I think that bigger hospitals pay even more. So that's not money you.
I had a deputy chief of EMS in our Southern Maryland area tell me that he was very happy about this because he just guesstimates that 80% of his calls that his group does is non-emergency. It's just what you said. They come up and they've got the suitcase, or they're ready to, they're lonely or something like that.
I would say that this is where it's important to also, again, to throw in the payer plug. This is Lorena again. We know who these people are. We have the data. We have all the information for those that are frequent flyers to all the hospitals, that are going to the ER, that are getting denied claims because they're there for social factors or for social determinant of health issues. I hate to be the stickler, right? But I feel like I'm probably the only payer representative at this meeting. And we talk a lot about providers and we talk about hospitals, but the payers really do have an incredible vested interest, as well as we have the data and the information that you're looking for to really help identify who the patients are. So please keep that in mind.
Okay, it is now 2:10. Do we have any more comments? Okay, I promised that we'd all be out of here by 2:30, so we have 20 minutes left to start working on our next steps. So just one last chance for comments or anything? Okay, well, our next step is that we're going to be having our, Jason, I was wondering if you could go back to the PowerPoint. Do I have control or is it you? Okay, right here. Our next meeting is in October 25th at Rocky Gap State Park. This is on the tail end of the Maryland Rural Health Association Conference. That's where I said we would be starting to take some of these comments and start trying to come up with some concepts, larger scale concepts, 30,000 square foot to about how, 30,000 feet in the air view on some ideas. We had a very good conversation today. I think we've had, it was very good today. I would strongly encourage everybody to attend that meeting. And if, that's when we're going to start really getting into coming up with some solutions. If you all have any other comments or, things that you want to send over, please email them to either me or to the Rural Maryland Council.
And the time for the meeting is 1:30 to 4.
Right. Thank you.
They can come to just the meeting, right?
Right.
Come to the conference if you like, but then this will be after the conference. That's the calendar.
Right. Yeah. Thank you.
Any other comments?
On behalf of the Rural Maryland Council, thank you all for being a part of this. Please let us know if you have comments or issues or questions or any information that you think we need to continue to collect. And we look forward to seeing you next month.
Yeah, I want to thank Charlotte and her staff for doing a lot of the coordination work in combination with the Southern Maryland Tri-County Council. And I want to thank sitting beside me, Scott Warner. Scott was one of the earlier chairman of the Rural Maryland Council, and he was the one that twisted my arm to take this position. So I'm trying to carry on in his footsteps. So we have been working in coordination with the Eastern Shore, and their work earlier and their work that done by Santo Grande here on the Eastern Shore is what informed our work that we've done in Southern Maryland. So we would like to improve this rural Maryland transportation throughout the state, not just in Southern Maryland, not just in the Eastern Shore. So out there in Western Maryland, we look forward to coming out to Rocky Gap and getting your direct input at a meeting out there. And we encourage you to attend when we're there.
Who's registered in here, right? So y'all might be hearing from us between now.
All right, I guess.
Thank you.
Thank you.